Hey everyone, let's talk about pulmonology. Fun? All right, so we're going to start talking about anatomy. Then we're going to go into way more depth than you probably need to know or want to know about surface tension. I think it's just helpful. Talking about the negative, explaining why surfactant's necessary, talking about the negative intrapleural pressure and how that and the surfactant keep the alveoli from collapsing. This is going to help explain atelectasis, where the lungs collapse, and pneumothorax, where air can get into the intrapleural space. We're going to talk about hemoglobin and hemoglobin pathologies, a ton about gas. Gas always confused me. I couldn't find good explanations online, so I could go into a little bit of depth there. This helps us understand the different forms of hypoxia. Then we're going to jump into obstructive versus restrictive lung disease, how you can differentiate them using spirometry. Emphasis on obstructive, emphasis on restrictive. Talk about pneumonia and how it can lead to acute respiratory distress syndrome, different types of lung cancers. Remember that lung cancer is the leading cancer death in, I think, not just the country, but the world. Circulatory tie-ins and sinusitis, talking about different types of x-rays and both normal breath sounds, but also adventitious breath sounds, and then different types of pharmacology, most of them being asthma drugs. All right, so starting with anatomy, talk about lobar anatomy, diaphragm, what to look for in x-rays and MRI, the cell types in the respiratory tree, and then NRDS, neonatal respiratory distress syndrome. All right, so as you know, we have two different lung lobes, or two different lungs. The one on the right has three lobes, so lobe 1, lobe 2, lobe 3. Really, lobe 2 is absent in the second one, so you can really just think of this as 1 and 3, so two lobes on the left. The middle lobe is really this little thing right here. It's kind of a vestigial feature. So they call this the lingula. The heart is going to rest right in here, so that's our cardiac notch. Of course, the whole thing is resting on the diaphragm, which separates the upper part of the thorax from the abdomen. So you'd have the liver right there and the spleen right there. Very similar to the pericardium, the pericardial sac that surrounds the heart, we have a pleural sac that surrounds the lungs. So and just like the pericardium, visceral is for the inside layer, parietal pleura is for the outside layer, and there's a layer of fluid on the inside. This prevents friction when the lungs expand and contract. And if this becomes inflamed, you have something called pleurisy. It becomes difficult and painful to breathe, and you can hear this grating sound, a pleural friction rub as the pleura run against one another. Trying to think what else. The apex of the lung at the very top, this is going to be by the clavicles. Cool. So when you're looking at somebody, the anterior part of their body is mostly going to be the upper lobe. Again, for the right lung, you do have this middle lobe, but it's mostly the upper lobe and on both sides. And then on the back, it's mostly going to be the lower lobe. So this is probably a good thing to keep in mind. You can see a better picture there. And of course, we have our little lingula right there. So food, if you aspirate food, it's likely to get stuck in the right lobe. That's because this is both wider and shorter, and it's more vertical. I mean, you can see that clearly from the picture. Now, if you swallow something while you're standing or sitting, gravity is going to bring that food to the right lung, and it's going to bring it down to here. So it's going to go to the lower part of the lower lobe. Now, different if you're lying down on the couch eating potato chips and you aspirate one, it goes into the right lobe probably. And now gravity is actually going to bring it to the upper part of the right lobe. Weirdly, if you're lying on your right side, then it's actually going to go to the upper lobe. The carina is where the left bronchus and the right bronchus are going to break off around the trachea. And the carina is really sandwiched in between. Because remember, when you're looking at this, the heart fits right in here. And again, we have this little cardiac notch right there. So I'm going to have my ascending aorta snake around this and kind of choke it with the descending aorta. So we have this here. The ascending aorta is going to go like that, and then it goes around right there. And there's my carina, or carina, not sure how to pronounce it. If you're looking at a chest x-ray, so here we have the ascending aorta, here we have the descending aorta, the pulmonary artery, and then again, the carina is going to be kind of sandwiched in between the two of those. You could think of this, sometimes it's, if you're looking at a chest x-ray, sometimes they just say lower, middle, upper apical. But you could also just kind of superimpose what we just learned over here. Here I have the upper lobe, the middle lobe, the lower lobe, here the upper lobe and the lower lobe, and the lingula is going to be right there. And diaphragm is, of course, separating all of this: liver, stomach, and spleen somewhere in there. Stomach, you're going to see a little pocket of gas often. So just don't confuse that with a lung pathology. It's below the diaphragm. We're not talking about the lungs anymore. The right hilum and the left hilum are two lymph nodes that are commonly going to be swollen and visible on a chest X-ray. If it's bilateral, it's probably sarcoidosis or tuberculosis. If it's cancer, it's probably unilateral, but it could be bilateral if it spreads to both. Apexes of the lungs are going to be up there. The right lower lobe, the right middle lobe, the right upper lobe, etc. Again, the anterior portion is mostly upper lobe. And we have this thing called the costophrenic angle right there. And it really should be an angle. So if it's not an angle, maybe you have a pleural effusion or some other pathology that you have to be concerned about. When you inhale air, your diaphragm is going to be pulled down. So this active contraction of your diaphragm pulling it down, and your intercostals are going to be pulled up and out. So that expands the rib cage. So the diaphragm pulling down, the rib cage pulling up and out is going to increase your thoracic cavity, increase your lung. Boyle's law: volume goes up, pressure goes down, air is going to flood in. And then exhaling is going to be passive. This is your muscles relaxing, doing the exact opposite process. I always like to remember that the last thing you would do when you're dying is technically going to be an exhale breath, not an inhale breath. This is kind of nitty gritty, but here we have our mediastinum. We saw the esophagus and the aorta and the vena cava are all kind of running together. So the vena cava, 8 letters. This is going to pass through the diaphragm at around the T8 vertebral area. The esophagus, we're kind of sneaking in an extra letter, is going to be T10, so that's 10 letters. Aortic hiatus is 12 letters, so that's T12 moving through. So the whole idea is that this is going to break off into a bronchi, and then smaller bronchi, and then bronchioles, and it's going to end, with it's like a big tree with the big trunk and big branches, smaller branches, and little apples at the very end. This is the whole name of the game. This is where gas exchange is occurring, and it has a ridiculously large surface area, 500 million alveoli, 100 square meters of surface area. More surface area means more possible gas exchange. And I mean, just for frame of reference, a tennis court is like 250, so it's like half of a tennis court. And blood vessels are going to snake around the alveoli, dropping off CO2, picking up oxygen. So if we can also if we look now at cell types, we can break down the bronchial tree into, 2 different parts. So we could kind of call this the conducting zone, and this over here is going to be the respiratory zone where gas exchange is happening. So the purpose of the conducting zone is one, to catch pathogens as they're coming in, but it's also to warm and humidify the air. There was very low resistance with the bronchi and the bronchioles. You remember from physics that if you add resistors in parallel, 1/r equals 1/r plus 1/r, this is going to lower the overall resistance. So it's rather low resistance. We have cartilage in the conducting zone. So here's cartilage. As you get down a little bit further, though, this cartilage goes away once you get into the bronchioles. Goblet cells produce mucus. Pseudostratified cells are columnar, and the little cilia are going to kind of just push this mucus with our pathogens and debris that we don't want upwards so that we can spit it out or swallow it, and it goes down and our acid deals with it. So that's the mucociliary escalator. We have club cells in our bronchioles. These are really going to be very much like type 2 alveolar cells. They secrete a surfactant-like substance, and then they're reserve cells, so they're really just stem cells that can replace other cells. Now that we go a little bit lower, we're now in the respiratory zone. This is probably where most of the emphasis is because this is where the alveoli are. We have macrophages here, so anything that did not get caught and pushed upwards by the mucociliary escalator, hopefully the macrophage takes care of. It's going to swallow the bad guys and alert the immune system. If you have heart failure, red blood cells might break down and heme gets out, and so hemocytoin-laden macrophages in the alveoli are indicative of heart failure. Type 1 alveolar cells, these are your classic alveolar cells where the oxygen and CO2 is moving right through them. Sometimes these are called pneumocytes, these are squamous cells, and this is going to be a great majority of the alveoli surface. Type 2, as we said, are very much like club cells. They're stem cells, so they can replace other type 2, but they can also replace the type 1. And again, the surfactant is necessary to reduce surface tension. Corticosteroids are necessary during gestation to help produce this surfactant. So what happens if we don't have this surfactant? So again, corticosteroids are necessary. So if we don't have them, the alveoli have high surface tension and are prone to collapse. It's going to look like this ground glass appearance on the x-ray. Risk factors: maternal diabetes, C-section delivery. Well, treatment, if they need corticosteroids to make the surfactant, well, let's give them corticosteroids. If they need surfactant, they don't have it, let's just give them surfactant. We also want to give an oxygen, but if you give too much oxygen, the oxygen might result in a retinopathy. And if you look here, you can see the type 1 pneumocytes where the gas exchange is happening here, here, and here. And then we have our type 2, which are very much mimicking the club cells. These are going to serve as stem cells to replace the type 1. And again, these are the ones secreting surfactant. And they're doing this from the lamellar bodies, which you can see right here. Surfactant is produced from lecithins. So lecithins is really just a phospholipid. We can look during gestation and see that the lecithin to sphingomyelin ratio should be above 2. If it's below 1.5, this might be predictive of NRDS. So again, below 1.5 means we don't have enough lecithins, which means we're probably not producing surfactant, which means maybe we can, provide supplemental exogenous corticosteroids to the mother. So here we're going to have gas in the alveoli. We have a thin layer of fluid and surfactant. Type 1 cells, type 2 cells. So the gas has to get through a layer of fluid. If we have pulmonary edema, if we have pneumonia or ARDS, there's too much fluid and maybe the gas can't get diffused through very well. If you have interstitial lung disease, so if you have fibrosis here, this basement membrane here might become too thick. So these are all things that you should think about. So the gas literally has to get through fluid. It has to get through the type 1 alveolar cell. It has to get through the basement membrane, the red blood cell, and the endothelial cell, and then it gets into the red blood cell. And so here it is our right atrium, our right ventricle, here's our left atrium, and in between we have the pulmonary circuit. So the pulmonary artery in a systolic can be 24, and then during diastolic it can be 9. Remember, we spend more time in diastole, so the mean pressure should be closer. Maybe 2/3 of it should be the diastole plus 1/3 of the systole. So about 14 is going to be the mean arterial pressure for the pulmonary artery. If it's above 29, this is diagnostic for pulmonary hypertension. I would keep in mind, we'll go over this later, that the alveoli have an oxygen pressure of about 100 to 105 and a CO2 pressure of around 40. Of course, this is going to change during pathology. Lungs are also resistant, not immune, but resistant to infarctions due to a dual blood supply. So in addition to blood just running through and snaking around the alveoli, similar to what we have with the heart, I guess the difference is that the heart, the endometrium's too, the endocardium is too thick for blood to diffuse through. Blood could technically come from the pulmonary capillaries, but we also have these bronchial arteries, which are snaking down and supplying. So if you get a blood clot in your legs, it goes to your lungs, you get a pulmonary embolism. That's obviously not good, but it'd be much worse to have it in your brain or your heart or somewhere, again, because the lungs can withstand a little bit of infarction, unlike other organs. Surface tension refers to a natural tendency for the alveoli to collapse. That combined with the elasticity of the lungs causes them to collapse. Surfactant reduces the surface tension, so this is going to prevent collapse. And the intrapleural pressure also pulls outwards on the alveoli, preventing their collapse. So we're going to talk about why lungs want to collapse, which I kind of just spoiled, how surfactant exactly helps prevent this, how the intrapleural space helps prevent this, and just in general, how the pressure changes of the alveoli and the intrapleural space all change during normal exhalation-inhalation cycle. I always just thought this kind of looks like an octopus or something, like quickly changing. Pretty cool. All right, we all have heard of surface tension. We're aware of surface tension. We talked about it in general chemistry, but what exactly is surface tension? How does it relate to alveoli? You look online, you look at videos on YouTube or whatever, you'll hear explanations like this. I personally don't feel like this is helpful at all. So we're going to go a little bit more in depth just because I feel like it really helps everything down the road become a little bit more digestible. So start with, of course, we know that, oxygen is more electronegative than hydrogen, which creates a general polarity of the molecules. The oxygen is negative, hydrogen is positive. Long story short, they're attracted to one another. So imagine that we're in outer space. We just have a bunch of water particles. How are the attractions going to look between all of these water particles? Okay, well, there's going to be attraction to the right between this one, and then one down between this one and this one. This one's going to go to the right and up and down. This one's going in all directions. So those should cancel. So this cancels, this cancels. So I shouldn't have as much movement for the inward ones. These should have a net movement forward. This should move in that direction. That should move in that direction, etc. If we play the logical consequence of this out, we get a spherical shape like this, where again, this cancels, this has a, notice that, if we think of our vectors, right, this is going in that direction, and this is going to the left and down, and this is going to the right and down. I'm going to get some net, this is my net movement inwards. So this is what happens in space. We just get little water particles that naturally form. Of course, this is what happens on land too, right? If I have a hydrophobic leaf, the particles naturally assume a spherical shape. We can ask ourselves, though, if we just think about like the free body diagram, think of physics and vectors, what I have right here shows that this should just continually accelerate downwards and downwards and downwards. So why don't I have this just collapse infinitesimally? Well, that's because we're not thinking about sterics, right? This particle is eventually going to get too close to that particle, and it's going to push it upwards, so that there's like a equilibrium between the pressures and the forces. So things will not collapse infinitesimally for that reason. So general rule is you're going to have some spherical shape like this. Surface tension is going to pull that way, and it's going to pull that way, and so we're going to say that the net is going inwards. We also have an outside pressure, which is combining to push this inward, so there must be some sort of inside pressure. Previously, it was just due to sterics, which is going to counteract this so that the thing does not compress, but the inside pressure should equal the outside pressure plus the surface tension, so it also shouldn't expand. So let's understand this with thinking about a water bubble. Is the pressure inside of a water bubble more or less than the pressure outside of a water bubble? Well, if they were equal, right? I have an outside pressure and an inside pressure. You might think they should be exactly equal, right? If the outside pressure is too big, it's going to continue collapsing. If the inside pressure is too big, it's going to continually expand. But remember that the outside pressure is collaborating with this net surface tension pressure. So surface tension comes in, outside pressure comes in, then the inside pressure going out has to counteract those two. So the inside pressure actually needs to be a tiny bit larger than the outside pressure. And this is just another picture. If you cut a bubble in half, the surface tension is going to pull it inside, and the inside pressure has to go outside. But remember that we also have an outside pressure, which is also pushing inside. And so the surface tension wants to collapse. We mentioned earlier that the elasticity, the natural state of the lungs due to the elastin is that they want to be a little bit smaller in volume. So they want to collapse. The alveolar pressure is going to counteract this. We have a lovely little formula here, the law of Laplace, where the collapsing pressure, 2 times the surface tension divided by the radius. If you think about that, when you exhale, you're putting a little bit of the gas outside, which means that your alveoli should shrink. And well, if that's true, if we think about our formula, a smaller radius means that we should have a large and collapsing pressure. So when are alveoli more likely to collapse? When is someone likely to have an atelectasis, where the lungs collapse during exhalation rather than inhalation because of this smaller alveoli? Or at least for the most part, we're going to see that this isn't exactly true because of surfactants. So we talked about why lungs want to collapse, right? They want to collapse because of surfactant. They want to collapse because of the surface tension, because of the elasticity. The alveolar pressure, we have gas in here, which is pushing outside. But you know what? It's actually not enough to fully prevent the collapse. We need 2 other things to help us out: surfactant and the negative pressure of the intrapleural space. So let's go into detail about how exactly these works. So surfactant is a lecithin, which is really just a phospholipid. These are amphipathic, these are detergents, these are emulsifiers. That just means there's a polar end and a non-polar end. So about 20 weeks of gestation, babies should start producing this. Corticosteroids are going to be helpful for this. You get the neonatal respiratory distress syndrome where their alveoli collapse. You can tell if this is coming by looking and seeing that the lecithin to sphingomyelin ratio is less than 1.5. And this is just we know this from biochem. You have these non-polar ends and these polar ends. This is a lecithin. This is really just surfactant. So how do these work? Normally, again, water particles are very attracted to one another. But here's my polar end, and here is my non-polar end. Of course, the non-polar end should be pointing towards air, because air is non-polar, and this fatty acid is non-polar. Now, this is polar and this is polar, but you know what? That's actually kind of a weak attraction there. So I don't really remember that the surface tension we previously had was because we have this strong left-right attraction between the water particles. I have a very weak attraction here. So this is going to cut down on the cohesive surface tension forces. And if you look at a bubble, the bubble looks like this, bubble looks like this. Again, I'm going to have very weak surface tensions forces. So it doesn't have this collapsing pressure quite as much. So again, we have our fluid here, and now the idea is that we know that this is lined with lecithins, which are phospholipids, which are really just created by the lamellar body of type 2 pneumocytes, and these really just cut down on the surface tension. This is a smaller force factor than I had previously generated due to the presence of surfactant. So earlier we talked about exhalation, inhalation, exhalation, the alveoli get small. So if you think about that, if your alveoli have one smaller than another, or the alveoli is collapsing before another one, technically this would be a high pressure and this would be a low pressure. And so the air is not going to go out like we'd want it to. Instead, it's going to go into this one. And that's obviously not where I want my air to run. Alternatively, if air is trying to come in, air is nevertheless going to want to go to this one. This is just a whole mess of problems. How does surfactant help this? Well, not only does it reduce surface tension, but think about this. Yes, when we think about the law of Laplace, this smaller radius means I have more collapsing pressure. But the smaller radius also means that look at the distance between these surfactants here. Look at the distance between these surfactant molecules here. I have a higher density of surfactant when I have a exhaled smaller radius alveoli. That smaller, that higher density of surfactant lowers the surface tension enough to offset the decrease in radius. So somehow, yes, smaller radius, more collapsing pressure, but that's offset by the reduction of surface tension, which is enabled by the higher density of surfactant. So it actually turns out that this will be an equal collapsing pressure as this one's collapsing pressure. So I have air flowing equally into both. All is right in the world. Term hysteresis. So think about trying to lift a weight against gravity. It's difficult, right? Pulling a weight from the ground up above your head takes a lot of effort. It's easier maybe to put it down because you're working with gravity. The same thing is true of your lungs and your alveoli. If I'm inhaling, I'm bringing in air, and that air has to fight the surface tension to expand the alveoli. That is difficult, so it requires more pressure to cause the inhalation. Exhalation is easier because the surface tension, the gas wants to leave because the surface tension is pushing down on the alveoli. We can envision this with a graph. So this would be if there's no difference, and this is the truth over here where there is an actual difference. So let's think about this. Let's make up values. Let's say that this is 5 units of pressure, this is 10 units of pressure, and our max value is 15 units of pressure over here. So if I'm starting here, let's do an inhalation. So red is inhalation. From 0 to 15 for inhalation, I guess I get my lungs about halfway filled at about 10 units of pressure. So inhalation to get half filled takes 10 units of pressure. What about the exhalation process? If I'm starting at 15 and I want to exhale 15 to 5 would be 10 units of pressure. So to empty them halfway would also require 10 units of pressure. So inhaling requires 10 units of pressure to get halfway, and then exhaling requires 10 units of pressure to get halfway. But this is a fantasy. This is not actually what happens in our lungs. This is what happens in our lungs. There is a difference. Again, think of the weight lifting above your head versus pulling it down, fighting gravity versus working with gravity. Again, 0. Now let's change this. Let's make this, this might be 5, and now let's say that this is 12.5, and then over here we have the max still being 15. So now when I'm doing inhalation, I'm going from 0 to 12.5. So to get half filled takes 12.5 units of pressure. And again, that is because I am fighting the surface tension. Now, when I'm exhaling, and these numbers are made up, they're just illustrative. But now when I'm exhaling, going from 15 to 5 only takes 10 units of pressure. So it took more pressure to inhale halfway than it took pressure to exhale halfway. So all of that is just explaining how hysteresis works. So surfactant reduces surface tension. That reduces the collapsing pressure. That is one explanation. The second piece of the puzzle is the negative intrapleural pressure. So again, this is our mediastinum. This is where our heart goes. This is the cardiac notch. Here is our parietal pleura. This is our visceral pleura. And then here is the intrapleural space. If the outside pressure is 760, then this might be 760, which is to say that the relative pressure here and here might be 0. So when we say that there's a negative pressure in the intrapleural space, we just mean that it's a slightly lower pressure, right? So 756, so we can say that this is a -4 relative pressure. How do we get this relative pressure, and maybe why is it helpful to have this negative intrapleural pressure? Well, assume that the pleural cavity is just the exact same as the outside and the alveolar pressure. Everything's 760. The lungs have a natural tendency to collapse because of our surface tension and our elasticity. The chest has a natural tendency to pull forwards. And so let's just play out what would happen. We would expand this volume. Expanding a volume, Boyle's law, means that I should have a lower pressure. This is now a negative pressure. But now this acts like a suction, like a vacuuming. This inward pull from this negative pressure is enough to counteract the elastic recoil of the lungs and the pull forward from the chest. So it creates this nice stability, this equilibrium. That is how it's created, and that's its purpose at the same time. This is just a prettier picture. We have this negative pressure. Don't be too obsessed with the numbers. -3, -5, doesn't matter. Outward pull, inward pull is going to be canceled out by this vacuum of the intrapleural space being negative. So if we're putting everything together a little bit, an alveolar pressure, which is the gases pulling out, the elasticity is pulling in, the surface tension is pulling in. Notice that I made my surface tension smaller because of the presence of surfactant, but now we also have this negative intrapleural vacuum pressure, -5, -3, pulling outwards. And I think of this as a suction pressure or vacuuming pressure. So the intrapleural space is actually, you can think of it as, sometimes it's called the intrathoracic pressure. And they have to be the same if you think about it, right? Because otherwise I'd have my intrapleural space and, here's my, I have my trachea and I have my esophagus. If they were different, if they weren't the exact same, if the intrapleural pressure was bigger, it would collapse on this, which is obviously terrible. If this was bigger, it would push outwards. I don't want either of those things to happen. So this has to be the exact same as the pressure here and here. This is useful because if we want to measure the intrapleural pressure, you put a little balloon tip tube thingy down the esophagus. And by measuring the pressure in the esophagus, you're also measuring the pressure in the intrapleural space. This can be super helpful for, atelectasis and pneumothorax, things like that. All right, now that we know this, how the intrapleural space works, we're kind of well equipped to understand the general changes in pressure during a respiratory cycle. So just to start, FRC, the functional residual capacity. So this is a normal breath. This is our tidal volume, up and down, inhalation, exhalation, just normally, not taking a deep breath or big exhale, just a normal cycle. So at the end of the exhale, maybe we have 2.2 liters left. This is the functional residual capacity. Technically, the residual volume plus the expiratory reserve volume, that is my functional residual capacity. So after a normal breath, now I'm at FRC. So at that point, I have my outside pressure. You can think of the relative or absolute, whatever floats your boat, 760 or 0. We are the same as atmospheric pressure inside our lungs, inside our alveoli. That's one thing to know. As we talked about, at this point, the intrapleural space here is just negative enough to cancel out the inward pull of the lungs and the outward pull of the chest cavity. And another fun fact is that the pulmonary vascular resistance is at a minimum when we are at FRC. If we're we're going to look at this graph a little bit more detail in a second, but the intraalveolar, also known as intrapulmonary pressure, is measuring in here. That's going to be this line that's kind of sinusoidal. This line that just dips down and then dips up. This is showing the intrapleural pressure. And then the difference between these is the transpulmonary pressure. For the most part, this is just the positive version of the intrapleural pressure. I'm sure this has some use, but for me it's silly because it's really just the same as the intrapleural pressure. They're usually the same. In fact, every time I see them, they're the same, but technically it is the difference between these two. Again, it is always a positive value. And of course, the volume of breath should go up for an inhalation and out during an exhalation. So looking at this in a little bit more detail, intrapulmonary, intraalveolar, intrapleural, intrathoracic, those are just synonyms. So I'm taking a big inhale. That is from here to here. But let's think about what happens halfway. So halfway through my inhalation, my lungs are expanding. Why? Because my chest cavity is pulling my parietal pleura outwards. This intrapleural space is getting larger, so this is becoming more negative. Now, same is happening as this becomes more negative. My lung pressure is now going to be higher than this, and so this is also going to cause the lungs to expand. The lungs are going to expand into the intrapleural space. They don't expand as quickly as the rib cage expands, but they're nevertheless expanding. So as my lungs are expanding, air doesn't really there's kind of a lag before air runs in. So the lungs are expanding, the pressure in the lungs decreases because the volume of the lungs is increasing, but air isn't rushing in yet. Now at this point where this star is, my lungs and my thoracic cavity are still expanding, but now air starts to run in because of the subatmospheric pressure of the lungs. With air running into the lungs, that actually increases the pressure now, despite the fact that the volume is still expanding. That brings the pressure up. It's the exact opposite for the exhalation process. For the exhalation, now my diaphragm is coming up, it's relaxing, my intercostal muscles are relaxing, so my rib cage is coming down and in. The volume is decreasing, and as the volume decreases, again, there's a lag where air doesn't exactly leave the lungs just right away. So with a decreasing volume, but air still in the lungs, my intrapulmonary, intraalveolar pressure should increase. So it's at a maximum here. Now, for whatever reason, the air gets the memo. It says, hey, Boyle's law, remember, we are now above atmospheric pressure. We should get the heck out of here. So it flows from low pressure to high pressure, and it leaves the lungs. This leaving of air now causes the pressure to go down. So let's just look at that again. You can imagine that this is FRC, so here this is 0, and it's the same as atmospheric pressure. This is the equilibrium pressure of the intrapleural space needed to fight the inward pull of the elasticity of the lungs and the outward pull of the thoracic cavity. That's great. Now I start expanding my lungs. This is going to get larger. This is going to now push into here because, this is now going from -5 to -7 or whatever, which means that the lungs also expand as does the intrapleural space. But no air is running in. So now what's going to happen, this is going to be a greater intrapleural space, makes it expanding faster than the lungs. Air has not run in, yet my lungs have increased in their volume. Now air starts to run in. This is going to now actually, despite the fact that the lungs are still expanding, this is going to bring the pressure to 0 again. But the intrapleural space is at a maximum now. Again, that we're now at this position right here. Now the opposite. I'm going to exhale. As I'm exhaling, the exact opposite happens. The intrapleural space becomes smaller, the lungs become smaller, but air does not leave yet. So this makes it smaller. That makes sense. This is positive too, because again, it's gotten smaller, air has not left. Now air gets the memo. Now air leaves. As air leaves, this is now going to decrease the pressure inside of my lungs. I'm going to be bringing it back to FRC at the end of expiration. All right, now that we have a better idea about surfactant, intrapleural pressure, elasticity, all of that good stuff, we can better understand pneumothorax, where air gets into the intrapleural space, and atelectasis, which is just where the lungs collapse. Often people confuse these. They're very related. Pneumothorax might be the leading cause of atelectasis, but technically they're different. Pneumothorax has 3 different versions. Atelectasis has 3 different versions. Not just kidding, it actually has a 4th version, but the 4th version is kind of rare. All right, pneumothorax. Pneumo, air or breath. Thorax is your chest. So when air gets inside of the chest. So bunch of different ways it can happen, but here's my intrapleural space, and we can see way too much air, more than there should be. You can see this on the MRI. If this was pleural effusion, it would be a little bit more opaque, but this is a very radiotranslucent. So here's my air, should not be there. Now, if something is a tension pneumothorax, it's like the more severe type of pneumothorax. So here there's way too much. You can see how like translucent this is because, again, the air shows up as black. So if there's way more air than there should be, it'll be a little bit darker. So one, that's a little bit darker than we have over here. And two, there's so much pressure that it pushes the entire trachea over to the left a little bit. You can kind of see that a little bit. It's deviating towards the left. Three basic types. So three basic types, but kind of six basic types. Closed is spontaneous, open is traumatic, and then tension. We're mainly going to go through spontaneous, traumatic, and tension, but some people call them closed and open. So closed is where you haven't been stabbed, you haven't been shot. You kind of have a leak in your lungs, and air is leaked out into the intrapleural space. The traumatic, you got stabbed, too bad. Now there's air in here. And then tension is just where there's a one-way valve. So maybe the main way of tension is you get stabbed, and so like air can get in, but for whatever reason, air can't get back out. But you could have a tension pneumothorax where it's actually just air leaks from the lungs and it's not allowed back in. That's also possible. So both a spontaneous and a traumatic pneumothorax could lead to a tension pneumothorax. So spontaneous, the name is helpful, right? So pneumothorax, air in the thorax and the interpleural space where it shouldn't be. Spontaneous, this one just kind of happens, right? So maybe people have too much air in their lungs, meaning too much pressure, like emphysema. Maybe they have weak tissues, like Marfan syndrome or something. Maybe they have a cancer, and that causes a weakness in the lining. But air leaks out of the alveoli. This forms air blebs. If it's a big air bleb, we call it a bulle. And here's just a picture of all of that air in the intrapleural space. It can cause atelectasis, meaning it can collapse the lung. But so we get this bleb. There's a break in the lung lining, gets in the intrapleural space. This is the hole in the visceral pleura. Now this buildup of pressure here. Now this buildup of pressure, we kind of saw here, it doesn't necessarily have to be equal to or greater than atmospheric pressure to collapse the lungs. Because if you think about it, we said earlier that it needs to be -5. Well, if too much air gets in here and it goes to -1, right, it's still below this 0 here, but that still might be enough to collapse this. So we call it primary spontaneous pneumothorax if it just happened for sort of no reason. Interestingly, we find that this happens with thin, tall males in like their teens, and if you hold your breath, it's going to increase the pressure and make it worse. I think of my friend here. Secondary is where there's just an underlying condition, weakened connective tissue with Marfan syndrome or cystic fibrosis, emphysema, lung cancer, any other underlying condition makes it secondary. Traumatic is, well, it's trauma related, right? You got shot, you got stabbed, you fell off of I don't know, you got into a car accident. This is where something rips through your fascia and your parietal pleura, and then air just leaks in from the outside atmosphere into your parietal space. A tension pneumothorax, again, this could come from spontaneous, it could come from traumatic. This is where there's like a one-way valve. So just think of like a really shitty inner tube. You blow air in, and then if you're not holding it, air will just leak right out, right? Well, now think of like a nicer, higher quality air mattress. You breathe air in, and then if you take a break for a second and talk to your friend, air shouldn't leak out because, again, air is only allowed in one direction. So with a nicer, higher quality valve, it's one way. You could have that happen, again, either with tension or traumatic, just I guess it depends on the details, that there's a rip in the lungs or in the thorax or something. Air can get out, but when air tries to come back in, it kind of pushes this thing shut. Very similar to the valves we have in our heart. Where if there's too much pressure, they then close the valve. So too much pressure can close this flap. And obviously, this is going to build to a higher... The reason this is more dire is because it builds... This one-way valve means more and more pressure will just build up until it becomes enormous. And then it absolutely will compress the lung. And again, it can shift the trachea over to the right side. It also can get so large that it actually compresses on the heart and prevents... filling of the atrium or ventricles or contraction of the ventricles. And we're seeing it on this side, but of course, everything we're saying could also, you can get stabbed on both sides of your body. Treatment for a tension pneumothorax, again, this is the building pressure, so we want to, time is very important here. A needle decompression. So you're going to stick a needle in here or stick a needle in there, and you're going to withdraw the excess air. Often you'll do this in a military setting. Someone gets shot. That's going to be really useful. So atelectasis, atal means incomplete. Ectasis means extension or dilation. So in other words, your lung collapse. So 3 major types. I mentioned that there's actually a 4th one: obstructive, compressive, adhesive, and contraction. So for obstructive, we have kind of like, let's just say a mucus plug, or you swallow a hot dog, it goes down the wrong tube or something. That actually happened. I was at Thanksgiving at my friend's house in kind of the middle of nowhere. And the dad was a doctor. He got called in because somebody swallowed a hot dog. And I thought, how do you swallow a whole hot dog, goes down the wrong tube? And 2, who's eating hot dogs for Thanksgiving? Anyways, so often this is post-surgery as well. So the anesthetics of surgery cause extrabronchial secretions, which can act as a plug or tumor. There's lots of things that can plug up this, but basically air is not getting in. Compressive is basically what we just talked about: pneumothorax or pleural effusion. So air or fluid is compressing on the lungs. Adhesive is you don't have surfactant, and this is just you have too much fibrosis. So like a restrictive lung disease, interstitial lung disease, and there's too much recoil. So we have a picture of obstructive, compressive, adhesive, and then the contraction. Technically as well, with I don't usually see this in chest x-rays, but the collapse of the lung, the decrease in volume can actually, so normally we know if it's a tension, it should shift the trachea in this direction if I had a tension over here. But actually if it's atelectasis, sometimes the decrease in volume could actually cause the trachea to shift towards the side of lung collapse. I don't usually see that, but I've heard it's possible. Obstructive, we have a big old mucus plug. Think about this. If air can't get in, what are the things collapsing the alveoli? Surface tension and elasticity. What are the things that are keeping the lung open? It's the pressure shown here, and it's the negative vacuuming suctioning power of the intrapleural space. So if we take away any 4 of these, this is going to explain our 4 atelectases. So the mucus plug means I'm going to have no more air, no more air. So less outward push of air means that I'm more likely to collapse. Compressive, I have either positive intrapleural pressure, like a tension pneumothorax, or just have a slightly, smaller absolute value of my negative intrapleural pressure. So we can get rid of this a little bit because of an effusion pneumothorax or tumor or something, and that's also going to cause a collapse. Alternatively, the LS ratio is less than 1.5. We don't have enough corticosteroids. Moms are diabetic. It's a C-section baby, anything like that. And the no surfactant means that the surface tension is going to be larger than this, and a larger surface tension is also going to cause a collapse or potentially cause a collapse. And then contraction is maybe you have too much, you had cancer, you have radiation, you took too much bleomycin or busulfan, you have, you inhaled too much coal dust or something, or just, idiopathic pulmonary fibrosis, too much elasticity. This can contract stronger, and a restrictive lung disease, and this is also going to cause a collapse. Let's talk about hemoglobin and some hemoglobin pathologies. We'll start by just going through the dissociation curve, which you guys should be relatively familiar with. Talk about carbon monoxide poisoning, methemoglobinemia, which is really just where the iron gets oxidized to a 2+ to a 3+ state, and then cyanide poisoning. So everybody should be super crazy familiar with red blood cells. Red blood cells carry hemoglobin. Hemoglobin carries oxygen. 4 oxygens per hemoglobin. There's cooperativity, where the binding at one subunit increases the likelihood that the next subunit will bind oxygen. Each of these subunits gets their own heme molecule, which has iron at the center. Hemoglobin dissociation curve. So here we have the arterial oxygen pressure, PaO2. And note that, so this is showing the oxygen dissolved in the plasma. Notice what a ridiculously, compared to the total amount of oxygen, majority of it is oxygen that's bound to the hemoglobin. So this is what's actually contributing to the pressure. And yet most of the oxygen is carried by the hemoglobin. So if we went from, let's say, like 30 to 60, that's an increase in 30 in terms of the PaO2. That is a tremendous increase in the amount of total oxygen content from, let's say here to like there. That's a ridiculously large increase. What if I went from like 100 to 130? That's almost no increase in the total oxygen, because we're pretty much, it's not going to, the solubility is all spent up. All of the hemoglobins are bound. That's mainly what pushes oxygen into the blood. And additionally, for the tissues at rest, We're really only going from, if we're starting at like 95, 98, 100% oxygenated hemoglobin, we're going to, I don't know, it's going to vary, but maybe we're going to lose about 20 to 40% of our oxygen in a normal cycle as we go from the lungs to the tissues and back to the lungs again. So we have this huge amount of reserves when hemoglobin travels through the blood, which is going to be important for a rainy day, right? If we're running from a bear or whatever. Now, this curve can be right shifted and down shifted. There's a tense version of hemoglobin that is likely to dislodge oxygen, and a relaxed version which is likely to bind or hold on to oxygen. So right shifting is going to favor the tense, left is going to favor the relaxed. So in other words, this is going to release oxygen, this is going to hold on to oxygen more tightly. So fetal hemoglobin binds more tightly. Carboxy hemoglobin, when CO binds, makes the subunits that don't have the carbon monoxide, those bind to O2 more tightly. Methemoglobinemia is complicated. The particular heme subunit, the iron that is oxidized to the 2+3+ state, that is a lower affinity for oxygen. But the other subunits, right, if only one subunit is oxidized, then the other three will actually have an increased affinity. So depends how many subunits are affected, et cetera, et cetera, et cetera. But we're going to overall say that there's an increase in affinity. 2,3 BPG or DPG is just, if you go up in altitude, you create more of this. This binds to, this is some negative thing that binds to positive amino acids within the hemoglobin, stabilizes the tense conformation. And now these three really go together. Now, what do high CO2, low pH, and high temperature have in common? Exercise. If you're exercising, you're exerting a lot of CO2. There's a high ventilation rate, a high cardiac output. Your muscles are consuming a lot of oxygen, generating a lot of CO2. So high CO2, that makes sense. You're going to be breathing more of that out, more of that's in your blood. CO2 combines carbonic anhydrase with oxygen and forms carbonic acid, which is an acid. That's going to lower the pH. Additionally, some of your muscles are going to switch over to anaerobic respiration. So you have a lot of lactic acid. Lactic acid, again, that's an acid. That is going to lower pH too. And look, sweaty, high temperature. All three of these things are going to collaborate. We evolved hemoglobins that responded to these three things to enter into the tense state, to relax the oxygen, which makes sense because if I'm exercising, I don't want to hold on to my oxygen. I don't, that 20 to 40% that we normally, cycle in, we want to go above and beyond that. Now it's the rainy day, we want to offload more oxygen, so we need the tense state. So that should check out. All right. The Bohr effect is really just that CO2 knocks off oxygen, and the Haldane effect is the opposite. Oxygen knocks off CO2. Now, specifically, CO2 is converted to carbonic acid, which dissociates. This hydrogen becomes bicarbonate. Bicarbonate travels in blood. That's 70% of the CO2. But this binds onto the hemoglobin, stabilizes the tense conformation, and that is going to make the oxygen more likely to leave. And pretty much the opposite for when oxygen comes into the picture. It's going to bind, stabilizes the relax, which kicks off the hydrogen. Hydrogen combines with bicarbonate, and the carbonic anhydrase reaction makes CO2, and then CO2 can be breathed out. This is in the lungs, this is in the tissue. When you go up in altitude, it's 21% of the atmospheric pressure is oxygen. That doesn't change if you go up in the air. It's just the total amount. So we might have 760 down here, and we might have like 400 up here, but it's still 21% regardless of where you are. And this is sometimes called a fraction of inspired oxygen, that 21%. So if you go to a high altitude, let's actually say that this is normal. So here's normal. Maybe we get like 100% of our hemoglobin saturated. And then when we go to the tissues, maybe this is going to be, let's use their numbers. This is going to be 62%, right? So we have offloaded 38% of our oxygen. And you might say, wait a second, what about the oxygen that was in the plasma? Remember, that is such a small part of the picture that we're going to, for the most part, disregard it. So we're really just looking at, we can more or less treat it as negligible. The amount of oxygen is reflected by the amount bound to hemoglobin. So we lose 62% of our oxygen normally. So what happens at high altitudes? Well, at high altitudes, you're going to have hypoxia, meaning you can't get enough oxygen in the blood because there's, instead of, there's just not enough getting in your lungs because there's so little oxygen, right? There's not a lot of atmospheric pressure. So maybe we're going to get occupied at about, I don't know, maybe this is, oh gosh, now I got to do math. This is 30%. So and I'm going to 62%, so I guess this is going to be 92%. So instead of getting 100% oxygenation, now we're just going to get 92% saturated. But when we go to the lungs, though, sorry, actually, that should be right here. So 92% is right there. That's how much we pick up when we're on Mount Everest. But, okay, so the important thing is that the tissue PO2 doesn't really change. It's only the arterial oxygen that changes, the amount coming into the lungs. The amount of the tissues is the same. So we shifted from here to here for lungs, but the tissue stays constant. So now if we're at 92% that we pick up, we're still going to offload. And gosh, now my numbers are all crazy off. Sorry. All right. The last thing, let's say that this is 80%. No, that's actually fine. Yeah, no, that's totally fine. So 92%, and now we're at 62%. So now we're only losing 30% of our oxygen. And well, we need to deliver 38%. We're only delivering 30%. That's not enough to feed our tissues. We now have ischemia. Or maybe not ischemia, but we're some sort of hypoxemia and hypoxia. To fix this, the 2,3-BPG is going to shift everything to the right. So yeah, maybe we pick up a tiny bit less oxygen now that we do this right shift. So yeah, the 92%, by the way, should have been over here. This is what I should have said, 92% to 62%. And now that I do a right shift, now I'm making up these numbers on the fly, which is probably a bad idea. So now we're picking up, let's say that the number is 89%. Yeah, let's do 89%. So now we pick up 89%, right? Because we did a right shift. So we're picking up a little bit less oxygen. Instead of 92%, 89%. This might seem counterintuitive. Wait a second. The whole idea is you want more oxygen. Now we have a tense hemoglobin that can't pick up oxygen, getting 89 instead of 92. Yeah, but the idea is, yes, it's picking up a little tiny amount, 3% difference in the lungs, but the effect on the tissues is so much more pronounced. Instead of going to 62%, now it's going to 52%. Right? So now this 89% to 52%, this is going to be a 37% delivery. So the amount delivered is what I care about. So that is why we're going to favor the tense conformation at high altitudes with 2,3-BPG and whatnot. Sorry, I kind of screwed that up, so feel free to play back. I screwed it up, but then I landed the plane. So what I said at the end is correct. Hemoglobin concentration, we got all these different terms. So hemoglobin levels really just reflects the amount of red blood cells, more or less, right? The more hemoglobin, the more red blood cells, assuming that you don't have some sort of like microcytic anemia where you're really crap at producing functional hemoglobin or hemoglobin period, right? You have normal levels of iron and things like that. Thalassemias, et cetera. Hemoglobin saturation more or less reflects is indirect measurement of how much oxygen you have in your body. If you have low hemoglobin saturation, you might have low oxygen. Alternatively, it might mean you have some sort of hemoglobin poison thing going on, or perhaps you have a just defective hemoglobin by some other metric. But so you could get two different things from the hemoglobin saturation. Dissolved O2 is really just saying how, what's our ventilation rate? How much oxygen are we bringing into the blood into the lungs? And then how well is that diffusing, doing the gas exchange at the alveoli with the pulmonary capillaries? And the total O2 content is going to be some sort of reflection of both of these combined. So carbon monoxide poisoning. So normal combustion where we have excess oxygen, notice this is a 2-to-1 ratio, makes CO2, which is fine. But if you don't have enough oxygen, you do what's called incomplete combustion. Now, this is a 4-to-5 ratio, right? We don't have as much oxygen compared to the amount of hydrocarbons that we used to have. Now you start to produce carbon monoxide. Carbon monoxide has these 3 resonance forms. Which one is the best? Well, this is the only one with a full octet on the carbon. So despite the fact that we don't want our carbon to have a negative and oxygen to have a positive, this is the best one. This is the one that you will see reflected because it is the full octet, the best resonance form. When will we have incomplete combustion, thereby producing this? You will have it if you have a car in the garage, the exhaust is running, incomplete combustion, and the garage is pulled down, so like house of cards, and it's going to fill and you're going to suffocate. Fires, just in general, are going to produce carbon monoxide. Heaters for your house might also produce carbon monoxide. Note that carbon monoxide is, and this negative is 200 times think of O2, right? O2 is, maybe there's a little bit of like van der Waals forces, instantaneous dipole-induced dipole stuff going on, but for the most part, this is a relatively nonpolar molecule. So oxygen, the affinity it has for a positive iron is going to be a little bit less than this C- has for oxygen, because, well, you know what? Minuses and positives are attracted, so it should make sense that this affinity is so much higher. Luckily, though, carbon monoxide is pretty crap at diffusing through the alveoli. It's diffusion limited, meaning it doesn't diffuse as fully as it would want. Like the blood's flowing through quickly to the pulmonary capillaries, that there's not an equilibration that is achieved with carbon monoxide. You do achieve it if you have healthy lungs with oxygen and CO2. So those are called perfusion limited, where the amount of gas getting in and out of the lungs is only limited by the amount of blood flow, not the amount of gas in our alveoli, but that is different with carbon monoxide, luckily. Carbon monoxide competitively binds with oxygen. We just saw that it's negative. It binds really well with iron, and if it binds, oxygen cannot. So less oxygen will be bound. That is why we're seeing all of these shifts. So if I have 0, that's what this is specifically showing oxygen hemoglobin. The more carbon monoxide, the lower this is going to go down, because carbon monoxide is outcompeting our hemoglobin. It also, though, we said that it has a left shift or an upshift on the hemoglobin dissociation curve, so it also inhibits the offloading of oxygen. So the other subunits that don't have the carbon monoxide hold onto the oxygen more tightly. This is called carboxyhemoglobin, or mono-oxyhemoglobin, not to be confused with carbanohemoglobin, which is where CO2 binds to the hemoglobin. Note as well that the blood will still look like red-ish, maybe a little bit overly red, which we'll get to, but the blood still looks normal, and our pulse ox might actually pick up a normal value, because while this is showing oxygen oxygen saturation, this is just picking up hemoglobin saturation, period. It can't differentiate between an oxygen and a carbon monoxide molecule. So this could be misleading. I could have severe carbon monoxide poisoning and have this value still be high. So signs and symptoms: cherry red skin. So I don't know if you necessarily get hemoglobin to be more red when it's bound to carbon monoxide. Quite possible, but you have a hard time offloading this carbon monoxide. So your venous, like normally we dump a lot of our oxygen off in the tissue capillaries, and then in the venous system, blood is blue because it's not filled with oxygen, and so it's blue, not red. But if carbon monoxide is there, it'll still look red. So this high venous amount of hemoglobin saturation makes people's skin look red. When you die, you have even more blood pool in your veins because your heart's not pumping anymore. So in the post-mortem, it's going to become even more pronounced, this red thing. But you can maybe see like cherry red lips or something on somebody who has carbon monoxide poisoning. The globus pallidus in the brain is going to have these little lesions. People are going to be dizzy. They're going to get headaches. And, of course, they might just pass out or have a seizure or die. Carbon monoxide also inhibits complex 4 of the electron transport chain. So the treatment is supplemental oxygen. Why? Well, this is normal hemoglobin bound to 4 oxygens. In comes along carbon monoxide, which has a 200 times affinity. It knocks off the oxygen, and we have this. Well, think of Le Chatelier. If I give so much oxygen, that is going to increase my products, which shifts everything to the left, which is going to cause offloading of carbon monoxide. That's A. Additionally, carbon monoxide can literally just combine with O2, and that forms CO2, and that gets rid of the carbon monoxide. So, yay, we definitely want to give supplemental exogenous oxygen in this case. Methemoglobin. So, iron is normally in the 2+ state. For whatever reason, just reactive oxygen species, it just occasionally is oxidized to the 3+ state. Now, when it's oxidized to the 3+ state, that particular heme group is now very low affinity for oxygen. Somehow, it has a conformational shift of the whole hemoglobin tertiary structure that the other subunits now have an increased affinity. So I guess the specific effects might depend on the extent of the methemoglobinemia. The blood becomes brownish. That can be diagnostic. And I would also note that the oxidized iron hemoglobin, heme group, has a slightly higher affinity for cyanide, which will come back into play in a second. So like we said, normally we're in this state, but just normal processes, we have free radicals all over our body due to cellular respiration, will oxidize this into the 3+ state. Nitrates also are going to further oxidize this. Things, our anti-malarial medications also, flavabines will also induce radicals, which can cause this to become more methemoglobinemia. Now, again, everybody who has normal phenotype, they have ways of reducing the iron back to the 2+ state with this enzyme. This guy online, I didn't name him this, but online he's people call him Papa Smurf. He went on a bunch of talk shows. Apparently he has a defect in this. Well, actually, I heard two things. One, I heard he had a bunch of silver, which he thought was a remedy for some illness. I don't know if that's true, but I also heard that he has a genetic defect, which means he cannot go from the 3+ state to the 2+ state, and so he can't bind on to oxygen very well, hence his blue characteristic. So now a treatment for this is methylene blue. Methylene blue is an alternative route to reduce the 3+ back to the 2+ that does not require this. So if you have a bunch of methylene blue, you can make this go back to the normal 2+ state. That's a good therapy. Cyanide poisoning. So apricot, peach, cherry, pits have tons of cyanide. There's an almond smell to cyanide. So a little bit of this amygdalin is in almonds as well. Not that much, not a high amount, and nobody should be eating the pits of these fruits anyways. Obviously, people commit suicide, Hail Hydra, with the cyanide pills, and Hitler famously. And so you're also going to have cherry red skin here. Why? Because your body can't use, so we're going to come back to this in a second. Cyanide inhibits, maybe more strongly than carbon monoxide, complex 4. And if complex 4 is inhibited, that means I'm just going to have oxygen levels build up, build up, build up, build up, build up. So my tissue oxygen levels are actually going to be really high, which means when my blood flows through, it doesn't really want to drop off oxygen because the tissue oxygen level is really, really, really high, which means we're actually going to have a really high venous concentration, or venous saturation of hemoglobin. So this high venous hemoglobin saturation is going to make this particularly red skin. And again, in postmortem, you're going to have more blood pooling in the venous system, so it's going to be even more pronounced. You have an almond smell. I've heard that not everybody smells this, and it's sometimes just too faint for anyone to detect, but theoretically, there should be an almond smell. All right, cyanide treatment. Hydroxycobalamin. This can bind cyanide, and you can pee it out more easily. Nitrates. These will oxidize the hemoglobin from the 2+ state to the 3+ state. This is methemoglobinemia. How is that helpful? Well, remember, methemoglobinemia, one weird point of it is that it actually has a higher affinity for cyanide. I guess that kind of makes sense, right? If we're making it from a 2+ to a 3+, it's going to be even more attracted to negative things. So now that it binds, it's not like I want my hemoglobin to be binding to cyanide, but if it's bound to the hemoglobin, it's not causing damage in my cells. So sequestering is sort of the lesser of two evils, and maybe we can slowly excrete it from our body over time. So this is a second treatment. Third treatment is kind of like the first one. Instead of binding, why don't you just convert cyanide to thiocyanate? Then it can be excreted out of the urine more easily. So for all of these, note that there might be slight homeostatic feedbacks, right? Where if your oxygen levels go low or high, you're going to make more erythropoietin, and then you're going to have more erythrophoresis. You might have more or less red blood cells, but at the same time, keep in mind that takes 2 weeks to complete, and most of these hemoglobin poisonings are relatively acute phenomena. So let's start with these three. These should not affect the amount of red blood cells on an acute level or the amount of hemoglobin that any red blood cell has. So that's going to be normal. Anemia, low red blood cells, or red blood cells aren't making iron or hemoglobin or something like that, heme. So it's going to be low. Polycythemia is going to be high. Let's think about hemoglobin saturation. So carbon monoxide, this competes with oxygen. So the amount of specific oxygen saturation is going to be low. But remember that pulse oxes just look at hemoglobin saturation period, not necessarily just oxygen saturation. So this actually might be high. Methemoglobinemia is going to be low. Yes, technically, when I oxidize one of the heme states, that makes the other subunits have a higher affinity. But depending on the level of oxidation, we can imagine if there's so much Fe2 pluses becoming Fe3 pluses, just there's very low affinity for oxygen, and so I'm overall going to have a low saturation level. For the cyanide poisoning, it doesn't. Usually, your arterial values are really just have to do with the lungs and how much air is being ventilated in and how much diffusion is happening. So nothing's going on with your lungs. So the actual arterial hemoglobin saturation is completely fine. The issue is the venous one is going to be high because, as we said, complex 4 is inhibited, so the tissue oxygen levels go up. So there's less incentive for the hemoglobin to then dump off the O2. So it holds on to it. So the venous saturation is up. This attributes to the, this helps explain the cherry red skin that we might find. And then we're going to pick up less from the lungs, I guess. But because we already had more and we're picking up less, again, you're going to have a normal arterial amount. So that one's a little tricky. The saturation levels are not affected in these. We just have more red blood cells or less red blood cells. None of these three are going to affect the amount of arterial oxygen, which pretty much hypoxemia just has to do with ventilation and diffusion and how much, how well we can do gas exchange in the lungs. Same thing for these as well. Now the total O2 content is going to be a little bit low in carbon monoxide. Again, one way you can think about it is if either of these is low, it's going to say that you're going to have a low total O2 content. You can't pick up as much because of the carbon monoxide taking the subunit, taking the active site in one of the subunits. Same with this. This is low, so that should be low. Both of these are normal, so this should be normal. I guess in this case, that's going to explain the low status, and that's going to explain the low status. Now, the treatments, supplemental oxygen, we said, can do a Le Chatelier shift to the left, kicking off carbon monoxide, or it can combine with oxygen to make CO2. Methylene blue is an alternative route to reduce the Fe3 plus state to the Fe2 plus state. Hydroxycobalamin binds and can be peed out. Sodium thiosulfate can convert it to thiocyanate, which can be is more soluble, can be peed out more easily. Nitrates are going to oxidize Fe2 plus to Fe3 plus. Fe3 plus can bind onto the cyanide, sequestering it so it doesn't damage the cells. What if I have anemia? Well, give somebody erythropoietin, they can make more red blood cells. Or you can just give them a transfusion. What if you have too much blood? Just do a phlebotomy, take some of that out. Remember that carbon monoxide poisoning and cyanide poisoning, these can be confused with one another because they both can produce the cherry red skin, especially the cherry red lips. They can also inhibit the electron transport chain, but we can mainly note the difference here and here versus here and here to differentiate them. Carbon monoxide and methemoglobinemia, both are going to induce left-shifted hemoglobin curves, but again, there are differences between the two graphs and the treatments that you should be able to differentiate them. All right, let's talk about gases and tons of equations and probably more than you need or want to know about gases, but I honestly went down a rabbit hole. For me, understanding the nitty-gritty of how the O2 and the CO2 levels change helps a lot with future pathologies, but again, don't feel pressure to understand, no pun intended, to understand everything. We'll go into the alveolar gas equation, a bunch of stuff about gas pressures and little tidbits, conundrums, fun facts, Henry's law, decompression sickness. Alveolar gas equation. All right, so big A always means alveolar. Anytime you see little a, it always means the artery. So how do we figure out the concentration of oxygen in the alveoli? Well, you can't just stick a needle in the alveoli to measure the pressure. That'll cause a tension pneumothorax, right? Or at the very least, a traumatic pneumothorax. You can't put an esophageal tipped balloon into the thorax because that just gets the intrapleural pressure. We want the intrapulmonary, intraalveolar pressure. So to do it, you have to use this fun equation. So this is the fraction of inspired oxygen. It is always 21% unless somebody's in a hospital and they are having supplemental oxygen, in which case it might be like 100%, and they could change the value. Atmospheric pressure, water vapor pressure, both of these things together are really going to be the amount of oxygen that hits your alveoli, minus this, which is the amount of oxygen that leaves the alveoli, that is consumed. And if you do the amount that enters the alveoli minus the amount that leaves the alveoli, you have the alveolar oxygen content. Specifically, how we get the amount that leaves the alveoli is the arterial CO2 pressure divided by the respiratory quotient. We'll go into this all. So as we said, this is really just like the sort of the concentration of oxygen in the alveoli, big A for alveoli. You could probably just memorize that it's around 100, CO2 is around 40. Now, atmospheric, we have 760 units of atmospheric pressure times 0.21 is like 160. So if it's 160, why is it 100 there? The reason is that water vapor and carbon dioxide lower the value. And we'll get into that. So 760, like we just said, this is about 21%, and this gives us about 161 in the atmosphere. Notice that there's almost no CO2, and there's a bunch of nitrogen, which we'll get to. Weirdly, argon, but let's ignore that. So why does the water vapor bring it down? Well, when you inspire, when you breathe in, when you inhale, you're breathing in 760 torr atmospheric air. This is dry. There's not that much water in there. But when you breathe out, you're breathing out a lot of water vapor. And when the air is coming in, you have even more water vapor in your pharynx, in your trachea, in your mouth. And the water vapor sort of competes. It pushes out a bunch of the gas that would otherwise get in, right? We're not entering into a complete vacuum. So if it's 760 out here at functional residual capacity, also is going to be 760 there. But again, there's a lot of water vapor on the inside and there's not as much on the outside. So the 760 that you inhale that comes in to your respiratory tract is going to be 760 dry plus wet, which means there's less, that 160 value of oxygen has to come down. So specifically to get, really the dry atmospheric pressure, the dry oxygen value, it's 0.21, but not times 760 minus the water vapor pressure. You do something similar to this when you collect stuff over water in Gen Chem. And you also see these little vapor pressure trees, and 37 degrees Celsius, it's about 45 atmospheres. So 760 minus 45 times 0.21 is about 150. So that is the amount of oxygen that's getting into your, maybe like your trachea, your bronchioles. However, we also need to keep in mind that the oxygen that gets into the alveoli, well, it's just as quickly, a lot of it's going to get sucked into the pulmonary capillaries. So if 150 comes in, I shouldn't expect it to stay 150. How the heck do we figure out how much oxygen is being consumed? That seems complicated. And it is complicated. There's a very clever but complicated mechanism to figure it out. It's this equation here. So a couple things. CO2 fully equilibrates with in the alveoli with the pulmonary capillaries, which means when I detect the pulmonary arterial CO2 pressure, it is about the same as the alveolar pressure. And that's going to often be true. So the alveolar pressure is about the same as the arterial pressure. So and again, we can't just detect P big A CO2. You can't poke a needle in the lungs, but you can do an arterial blood gas draw to detect that value and say, oh, okay, interesting. The PaCO2 is something like, 40. But again, I want the oxygen consumed. I don't care about how much CO2 is in the alveoli. Well, remember that like cellular respiration, the amount of CO2 you generate is pretty proportional or correlated with the amount of oxygen consumed. And you might go, oh, wow, okay, genius. So if there's 40 units of CO2 in the lungs, that means that we must have used 40 units of O2. Almost, except that not everything is carbon. We don't just, it depends. If you're only eating raw glucose, then maybe it is 40 equals 40. But we're also eating a lot of fats, and in a Western diet, we have a different metabolic pathway for this. Notice here, 145 with 102. So this 1-to-1 ratio gives us what's called a respiratory quotient of 1. This 145 to 102 gives us a respiratory quotient of 0.7. At the end of the day, it varies from person to person. It's going to be about 0.8 in a Western society. So 40 units of CO2 in your alveoli really means that we must have consumed 50 units of oxygen, which means 50 units of oxygen leave the alveoli. So if we have 150 units of O2 coming in and 50 units coming out, that's where the 100 units of O2 kind of more or less sitting in your alveoli comes from. Now, that's good to know, but honestly, a much more useful heuristic that you'll see a lot is that CO2 in the alveoli will crowd the alveoli. More CO2, kind of like similar with water vapor. If there's more CO2 here, it's difficult for more O2 to get in because it's already occupied by a lot of CO2. So we're going to consider them mortal enemies. If CO2 is high, O2 is going to be low. It's a very useful rule of thumb. And you could also just think about the formula, right? If this is my formula, the alveolar oxygen value is if I increased this just in the formula, just mathematically, for ignoring the concepts, if I increase that value because it's a subtraction, this value will have to go down. So we can think of this. You can think of them being mortal enemies, or you could just literally go ahead and look at the formula. 3 different ways to come to that conclusion. All right. So the formula, in a nutshell. The alveolar oxygen is the amount entering minus the amount leaving. The amount entering is the fraction of inspired oxygen, 21. We have to subtract the water vapor to get the dry air, and then the amount leaving. The amount leaving is, well, the arterial CO2 pressure is really the same as the alveolar CO2 because of perfect diffusion and equilibration, but we get about like a 0.8 ratio, right? So every 10 oxygen consumed will generate about 8 CO2. So we have to divide by 0.8. And so we get this 150 minus 50. And so we have about 100. So again, 160 comes in. It's 150 when we consider that's humidified. And then it's 100 here. The CO2 values, on the other hand, are going to be, there's very little in atmosphere. It's going to be about 40 in here. And it's probably good just to focus on this. Oxygen, after it goes through the tissues and is used up, is about 40. The CO2 value is about 46. And when they leave, it's going to be 100. We picked up a bunch of oxygen. We dumped off a little bit of the CO2 going from 46 to 40. It's actually the arterial oxygen is usually going to go a little bit lower, actually. It's going to go to 95, which is weird, which we will talk about right now. All right, so again, I'm going to go a little nitty gritty with a lot of this stuff. So, feel free to, I guess, tune out a little bit. A lot of it will be relevant and helpful, but just don't, it's not super high yield. I just wanted to understand it. And I felt I was running into conspiracy theory after conspiracy theory with how they were explaining it online, made me go a little crazy. So weird tidbit, conundrum, conspiracy theory number one to tie up. Shouldn't we just expel all of the CO2, right? Why do we have 40 CO2? Shouldn't it be maybe like 40 CO2, but then 0 CO2, like after we exhale? That seems weird. So that's number one. Number two is if we looked at this, if this is 40 and 46, well, why does it perfectly match? And this is 140. Why is this now 140? How do the pulmonary capillaries, or really the pulmonary veins, now become identical to the alveolar pressure? And why didn't the alveolar pressure change at all, right? Shouldn't this value change that value? That just seems super weird to me. 3, why is the pulmonary arterial oxygen lower? Yeah, so I just said that this, in the pulmonary capillaries, it'll be 100. But quickly, as you go into the pulmonary artery and just the systemic arteries, it dips to 95. That seems weird. Why does it dip? 4, why is it that it's 45 for CO2 and it's 100 for O2? Again, shouldn't it be kind of close to being the same? Or a different way to think about it is the idea that the amount of CO2 entering the alveoli is about 5. So it was 46 in the pulmonary artery, and then it was about 40 when we look at the pulmonary vein. So why this drop of 6, this drop of 5? While the gain in oxygen is about 60. We have 40 in the pulmonary artery, and we have 100 or 95 when we consider the drop a little bit after the pulmonary vein. So that's another way of articulating mostly the same question, the same point. And then lastly, if nitrogen is so abundant, right, it's like 78% of air, why don't we see it as part of this whole system? So let's go through these one by one. Hopefully it'll shed a little bit of light on how all of this is working. Well, the reason we don't expel all of the CO2 is that you got to remember, this is a tidal volume breath, right? You can fit, 5 or 6 liters of oxygen gas in your lungs. You're only normal 500 in, 500 out, unless you're taking a super deep breath in or super deep breath out. So that's 15%. This 15% is going to mean that we're not going to drop all of our CO2. We're going to drop a small value. 2, why does the capillary gas value equal the alveolar gas value? Well, there's equilibration. CO2 diffuses super well. Oxygen diffuses pretty well. And in a normal, healthy person, if I have 45 units of CO2 as it's coming into the alveoli, quickly the CO2 is going to become in equilibrium with the alveoli, and the alveoli one is at 40, so it's going to bow and become 40. Same thing over here. It's 40 coming into the alveoli, the pulmonary artery, and as it's leaving the capillaries, the pulmonary vein now is going to be about 100. It's going to match what the alveoli is. So it's perfusion limited. It's going to fully diffuse and equilibrium will be reached. That doesn't really answer the question, right? Because we should still say, okay, wait, it's an equilibrium. Well, then why doesn't the alveolar gas meet it halfway, right? Shouldn't that value change? The reason it doesn't is because the amount of gas in a capillary is usually about 100. Or at least like the amount, if you take a snapshot in time, the volume of capillary that's wrapped around an alveoli is about 100, while the alveoli itself has about 3,500, 3.5 liters of gas. So it's like a drop in the ocean, right? It would be like dropping 100 milliliters of 20-degree waters and 3.5 liters 100-degree water, and then being surprised when the final solution is like 99.7-degree water, which we can more or less just call 100. So the truth is the alveolar gas values do change a little bit, but it's a negligible value, right? We're saying that it's more or less staying the same because its volume of gas is there's just so much more here than there is here. So it makes sense that these values shouldn't really change, and then these values will, at the end of the day, become identical to the alveolar values. All right, well, why does the arterial value drop? We've talked about this before. There is a dual blood supply to the lungs. There is also a bronchial artery that's feeding the lungs, and that if there's a bronchial artery, there must be a bronchial vein, which is deoxygenated. We know that deoxygenated is 40. So if this is 104 in the pulmonary capillary, and now here we're coming into the pulmonary vein, the pulmonary vein is going to combine with the pulmonary vein is oxygen rich. The bronchial vein is oxygen poor because this is like a normal vein, and this is like our one weird pulmonary vein that's oxygenated. And they're going to mix here, and this 104 is going to drop to 100. And don't take these numbers too crazy seriously, right? If I say 104 to 100 or 195, tomato. Alternatively, a VQ mismatch, we don't have perfect ventilation perfusion ratios all of the time. Sometimes I might have some alveoli that are just stinkers. They're pulmonary edema, there's pneumonia. Who knows what's going on? Maybe there's fibrosis, the diffusion stinks. Maybe I have a shunt. Maybe I have a little bit of a PFO. There could be tons of reasons that some of these pulmonary arteries just don't ever pick up any oxygen. So they were 40 and they stay 40. They stay 40, stay 40, stay 40. Now these numbers are misleading. In this picture, we can assume that there's a few bad eggs, a few bad pulmonary arteries, and mostly good pulmonary arteries, now pulmonary veins, that are having perfect diffusion of gas. So there's a bunch of these hundreds, a few of these 40s, but when they mix, it's now 90. So this would be a VQ mismatch issue. Ideally, this is somewhat mitigated by hypoxic vasoconstriction, where I'm going to reduce the amount of blood flow that's going to these bad alveoli so that this number, instead of 99, might be like 98, and it's not as big of a deal. But I would say that this is probably the main reason to account for the drop from here to here. All right, so why in general is the alveolar CO2 pressure, we said it was like 40 versus the 100 of PaO2. So things about to get really complicated. Again, don't have to know everything, but I do find it helpful, at least personally. So the amount of, let's just think about this. This is just a straight up, we just did this, the alveolar gas equation, right? How much oxygen gets into the alveoli from the atmosphere? It's 150 once we take the humidification into account. The amount that leaves is the amount of CO2. Should be about 50 that's leaving. So we have about 100 oxygen that sits in the alveoli. What about the CO2? Well, we're producing about 45 units of CO2 in our blood, and when it gets into the pulmonary, when it gets into the alveoli, well, the endothelial and epithelial tissue, the pneumocytes, they're generating. They're cells. They're living. They're generating a little bit of CO2 as well. So it should go 45, 46, 47. Goes up a little bit. Now, this 0.85 is that we take into account that we are breathing out, and we're breathing in air that has almost no CO2. So it's kind of like 0.85 times like 47 plus 0.15 times 0 because there's no CO2, right? It's the amount we're looking in the alveoli is an average. And so this 0.85 times like 47 times plus 0.15 times 0 is going to give us about 40. So that is like the average of the inhalation and the exhalation values. All right, it doesn't fully explain everything, right? Because we could still ask ourselves, okay, well, let's not look at it from the alveolar perspective. Let's look at it from the tissue perspective. Why is it the case, we just take it for granted that it's producing 45? Why doesn't it produce 100? Two things. One, remember the respiratory quotient. If you consume 10 oxygen values, you should produce about 8 CO2. So the value should be a little bit smaller, first of all. But second of all, we have excess oxygen. That's the whole point, is that we have tons of reserves. You shouldn't have reserves of CO2 because that's garbage, that's trash, that's the byproduct that's being generated. So because we have reserves and we're going from like 100 and we're dropping off 37 or 38% or whatever, we're still going to have a little bit left, right? We're going from 100 to 40. We're not going from 100 to 0. We're not using it all. So there should be more oxygen than CO2. But that still doesn't fully, it's still a bone to pick with this. Because if we just look, whether you look at the alveolar change or the tissue exchange, it's kind of the same issue. Let's look at the tissue exchange. Here, my oxygen value was 100 because of the bronchial vein dilution. It's now 95. So, okay, 95. And then, on the venous end of the capillary, it's now 40. So I went from 95 to 40. So it's a 55 exchange for the O2. Well, what about the CO2? The CO2 goes from 40 to 45. So it's a gain in 5. 40, it should be minus 5. It should be 45 minus 40 equals 5. There we go. So it should be 5. So in other words, why doesn't the 55 drop in oxygen equal the gain of 5 in CO2? And we just talked about the respiratory quotient, but that's not enough to account for this tremendous disparity. So how do we explain this? First is just a reminder that the amount of pressure we see in solution is really just to do with the dissolved amount of gas, not the total amount of gas in the blood, the amount dissolved in the blood. Second is that sequestering proteins like hemoglobin, they might increase the solubility of something, but increasing the solubility doesn't necessarily increase the amount of dissolved particles, so therefore it might not increase the amount of pressure. So let's look at this. We have 6 orange things in solution. So 1, 2, 3, 4, 5, 6, 7, 8. I'm trying to think. 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7, 8. You know what? I'm going to go off on a limb, and I'm just going to call this 8. Maybe it's 6. Doesn't really matter. So there's 8 things in solution. So let's say that the pressure is 8, and then the solubility is 8. Okay, well, what happens if I put a bunch of sequestering proteins in here that bind to these things? This throws off, so we had an equilibrium. Every one that leaves accounts for one that enters. But now we have a bunch of sequestering proteins. I have less proteins that can leave, which means more will come in than will leave. So this throws off the equilibrium. So again, like we said, there's more coming in than will leave. So over time, we're just going to note that we have a increased solubility. Solubility means the maximum amount of gas particles that could get into solution. I count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. But in terms of the free values, the free dissolved particles are the only one actually contributing to gas pressure. It's still 8. So notice that adding the sequestering like hemoglobin like protein increases the solubility, but it does not necessarily increase the pressure because the amount of dissolved particles at the end of the day is more or less the same. That's just a general concept, a general rule of thumb. The point being that the 55 loss and the 5 gain, there might be more going on behind the scenes with the solubility and sequestering proteins and secondary formation reactions and things like that. So starting with the oxygen, its solubility is considerably increased by sequestering hemoglobin, like we just saw on the last slide. What we talked about in a previous section, the dissolved O2 is a very small proportion of the overall O2. The hemoglobin holds on to a vast majority of the oxygen. So this is the only thing that's directly accounting for the pressure. So again, there you go. So CO2 is even more complex. Its solubility is altered. It does bind to hemoglobin a little bit. It also, majority of it is stored as bicarbonate through this reaction, which we should be familiar with, which is powered by carbonic anhydrase, and it forms better non-covalent bonds, so it has increased solubility. Oxygen is nonpolar. This is also nonpolar, but at least there's a dipole moment where this negative could be attracted to that positive. So CO2 is about 25 times more soluble in even just water, I think, than oxygen. So I would know that CO2 is about 5% dissolved in the blood. The bound to hemoglobin is going to be about 25%, and then the bicarb is going to be about 70%. So again, CO2 comes in, some of it binds to the carbaminohemoglobin, binds to the N-terminus of one of the polypeptides. Carbonic anhydrase makes it by carbonic acid, which becomes bicarbonate and an H+. The H+ binds to the hemoglobin, stabilizes the tense conformation. This is really just what the Bohr shift is. And then we have the exact opposite process happening in the alveoli. So if we could measure, just to understand at least this second point, if you can measure the pH at the arterial versus the venous end of the pulmonary capillaries, what would you see? You have way more CO2 on the arterial end, which means you should have more H+, which means the pH should be lower. But after you breathe a bunch of the CO2 out, this is going to move down, which means Le Chatelier is going to shift everything to the left. I'm going to lose H plus, and if I lose H plus, the pH should increase. This is just a better picture. CO2 can become, bicarb, which goes out here. The H plus can bind, this is the Bohr shift, stabilizing the tense, kicking off hemoglobin. Some of it binds to the amino terminus, and about 5% or so is just dissolved. But again, this dissolved one is the only one that actually contributes to PCO2. All of this to say that at the end of the day, I don't really have a good answer. I mean, it's really difficult to get any precise quantitative conclusions without knowing the weights and balances of different considerations. But just, I guess, two last things. So not only is CO2 more soluble, so being more soluble just means that we can squeeze in more CO2, or at least more easily with less pressure. But it's actually also dissolved more. Remember that solubility and being dissolved are different. So 5.9% of CO2 is actually dissolved compared to 1.5% of oxygen. This might make somebody think that therefore CO2 is going to be a higher pressure, but this is likely offset by a larger total amount of oxygen gas, despite the higher concentration of the CO2 gas being dissolved. Additionally, the oomph that a partial pressure exerts is going to depend somewhat on the solubility of that thing in solution. So the partial pressure is equal to the concentration of the dissolved gas divided by the solubility coefficient. One way to think of this is that the pressure, like, if we say that PO2 is 40 in the gas, what we mean is that if we had, this amount of blood in a beaker, the vapor pressure necessary to push that particular amount of CO2 into solution would need to be 40. So the vapor pressure would need to be 40 to get X concentration into the solution. And well, if something's really soluble, S equals Kp, Henry's law, we don't actually need a large pressure to push a certain amount of it into solution. We can see that here with an example. You can imagine something that's 10 times higher solubility in a lipid than in a water. So it's really easily dissolved in a lipid. So we have a lot of it. The contents is 100 and the pressure is 100. On the other hand, for water where it's not very soluble, maybe we have way less. We only have 10 units of this particular mystery compound X. And yet the pressure is the same. And again, if you think of it over here, it's because for the liquid, we would need not that large of a pressure, just 100 to push a huge amount of this into solution because it wants to go. While if you're looking at the water, you would need that same pressure just to even push a small amount in because it's not very soluble. Point being that because CO2 has such a high solubility, it might not quite exact the same amount of pressure as an equivalent amount of dissolved O2. Enough with this. This is all just food for thought. Lastly, is just to consider the nitrogen. So if nitrogen is the dominant thing of atmospheric composition, why is it not ubiquitous in our blood, right? It's 78% here, so why don't we talk about nitrogen in our blood? Why doesn't it get through? Well, it turns out it does get through. We just don't really talk about it because it's inert. It's not reactive, right? Nitrogen has this triple bond. It doesn't really want to react with things. It's happy as a clam. It is a great stable, low energy condition. So this is atmospheric, then inspired, alveolar, arterial. Notice we still have a lot of N2. N2 makes its way into our body for sure. It just doesn't do anything. So Henry's law, again, solubility is the total amount that you can put into a liquid before it becomes saturated. This depends on the solubility multiplied by the pressure. So a couple of things. Oxygen, 0.013, CO2 is 0.034, carbon monoxide is 0.0095, and this is 0.0061. So all of these are low K, low K, low K. Now, we have a high solubility of oxygen in our blood because it's a particularly large pressure. CO2, I guess we have a large amount in our blood, but that's largely because, not because of the pressure is necessarily high, but because its solubility is so very high. And then for carbon monoxide, the solubility is increased by hemoglobin, CO2 is increased by hemoglobin, also its conversion to bicarbonate, and then carbon monoxide is also technically increased by hemoglobin, but it's luckily not very abundant in the atmosphere. So nitrogen has a low solubility constant, but it's so damn abundant that it pushes its way into solution anyways. Everything below of this is really just articulating something that we've already seen with bicarb. You see this, the solubility product constant equilibrium in GenChem. If I want to dissolve a little bit of silver chloride into solution, it'll have this particular solubility. This is just pure water. If I want to dissolve it into the same solution that has a little bit of ammonia, and if I know that ammonia has a very favorable forward complexation reaction with silver, the idea is that all of the silver that dissolves will be consumed in this second reaction and going forward. So this drops this, which makes this even want to dissolve more and more and more and more. So the solubility increases. So we see the same thing with the bicarb and CO2. The conversion into bicarb is going to drive the not necessarily the dissolving like here, but the solubility, the desire to go from the gas phase into the liquid phase. So what happens with nitrogen? So we have my friend Jeff, now we got my friend Mitch. What happens if you go into Thailand and you go diving? So the pressure is relevant here. The increased pressure when you go underwater, if this is my scuba tank at atmospheric conditions when I'm in land, when I go deep underwater, not even that deep, even 50 meters, it's going to compress all of this gas into a very, very small volume, this high pressure of gas. So this is the alveolar gas equation, but instead I've just made it for nitrogen. The idea is that 760 now becomes a lot when you go underwater. And this is, so we had a little bit of this going to our blood. Now I just have a ton. I just have a ton of nitrogen going inside of my blood when I go underwater. Now you might think, well, wait a second, why? That's not just nitrogen, and you'd be right. Technically, this would happen for any gas that is under high pressure when you go scuba diving. The reasoning is that really the scuba tanks though only contain nitrogen, helium sometimes, and this could be an issue, except that it's usually pretty high cost to have helium in your scuba tank, so it's usually just going to be nitrogen. Even still, nitrogen is higher. Oxygen is also in your scuba tank, obviously, because that's what you're breathing in to live, but it's sequestered by hemoglobin, right? So if I double the amount of pressure of my inspired oxygen, that doesn't necessarily equate with a double the amount of dissolved oxygen in my blood. So a lot of it gets soaked up by the hemoglobin. So the main one that we're really worried about is the nitrogen, maybe the helium, maybe the oxygen a little bit, but I'd say mostly the nitrogen. So here's us close to the water. When we go underwater, the higher pressure pushes nitrogen through the alveoli into our blood. Now we have more dissolved nitrogen. Now that in and of itself is not dangerous. The problem is if you come up too quickly, now the nitrogen that's dissolved, the solubility decreases and it starts to precipitate and it forms these bubbles. Very much like we see in GenChem. You have an unsaturated solution, a saturated solution, and supersaturated. Supersaturated, the concentration is higher than wants to fit in the solution, and so it'll start to precipitate and form crystals. Here, instead of precipitating and form crystals, it'll form bubbles. The same thing happens when I have a Coke. It's high pressure. This higher pressure makes all of my particles dissolve safely into the solution. But you know what? When you open it and you let all of this this gas out, the pressure becomes low. The pressure going low changes the solubility. It now is super saturated and it's going to start to bubble up and precipitate out of solution. You get these large bubbles. Seen here, and the same thing happens in your blood. You will get nitrogen bubbles. Could be a helium bubble as well. Okay, now that we understand how to calculate alveolar oxygen gas concentrations and understand arterial gas concentrations, let's talk about a hypoxia and hypoxemia. So start with a couple of just general terms, talk about the AA gradient, all of the different types of hypoxemia, one, high altitude, hypoventilation, VQ mismatch. VQ mismatch includes dead space and shunts, which is often considered a fourth and separate form of hypoxemia. Diffusion limitations, talk about the diffusion formula, what diffuses well, what doesn't, perfusion limited, diffusion limited, and how exercise affects it. And then we'll just go into how supplemental oxygen is going to affect each of these 5 different hypoxemic conditions. A couple terms: anoxia is the absence of oxygen delivery to tissues. Hypoxia is just decreased oxygen delivery to tissues, not to be confused with hypoxemia. Remember that emia is anything to do with the blood. So hypoxemia is just low arterial oxygen content, a low PaO2. Hypoventilation really just means that, ventilation is the process of getting air in and out of the lungs, so you're not getting enough air in and out of the lungs. This could be a low ventilation rate or low tidal volume. Ischemia, again, emia is blood, so this is insufficient blood flow to tissues, and then infarction would be a complete absence of blood flow to tissues, which results in necrosis. So a clot could lead to ischemia or an infarction, and that could lead to hypoxia. Alternatively, hypoventilation and the other conditions, high altitude, VQ mismatch, shunt, and diffusion issues like interstitial lung diseases could lead to hypoxemia, low arterial oxygen blood content, which could lead to an absence or deficiency of oxygen content in the tissues. Just to really make sure everyone has the terms clear. Causes of hypoxia. Your heart stinks, cardiac output, you've got an arrhythmia, you've got a heart failure, you're just not pushing out blood, dilated cardiomyopathy, hypertrophic cardiomyopathy, etc. Ischemia, maybe because of a clot. Anemia, maybe you're anemic, you have a thalassemia, you have an iron deficiency, you have, you have a hemoglobin poisoning, you have carbon monoxide or methemoglobinemia. So your hemoglobin is either in the oxidized state or it's all soaked up and just is not binding on or is binding into oxygen very well and is not letting go of oxygen very well. Cellular poisoning, so cyanide, you can't use your oxygen because complex 4 is being inhibited. Beriberi, you can't go through aerobic cellular respiration because you need thiamide to fuel the pyruvate dehydrogenase complex. And then hypoxemia is the one that we're really going to focus on here, where we're not getting enough oxygen into the blood. And so normally this should be about 80 to 100. So anything less than this is going to be considered hypoxemia. So to get a good grasp on hypoxemias, first we should understand AA gradient. So last time we said that A is the alveolar and little a is arterial. Arterial, you're simply going to get from an arterial blood gas draw. And then the P big AO2 is just the alveolar gas equation, the amount of oxygen that gets into the alveoli minus the amount that leaves the alveoli. In a perfect world, the AA gradient is going to be 0. All of the values that are in the alveoli get into the arteries. But remember that the bronchial veins are going to dilute it a little bit, so it's going to bring that number down 104 to 100 because some is coming in here. But additionally, we're going to have some level of VQ mismatch. And just in general, like you're not going to get 100% through, like nobody's built perfectly. And as you get older, the body just becomes shitty and it breaks down and you can't get gas in or out as well. And things become fibrotic, diffusion doesn't work as well. So the gradient for like a normal young healthy person is 5 to 15. So if a 15-year-old comes in and their AA gradient is like 25, they probably have some underlying pathology. If somebody is 70 and they come in and their AA gradient is 25, maybe that's, obviously it stings and getting old arguably is a disease, but they don't have some underlying pathology. I'm not worried that they're suffering from a pulmonary embolism or something like that. The formula to calculate the AA gradient is there's a couple, but 0.3 times the age plus 4. And hypoxemias fall into 2 types. Those that do not increase the AA gradient. So here the idea is that we have trouble getting oxygen into the alveoli, so there's a barrier sort of here, or those that do increase the AA gradient. So here we can get oxygen in fine. It's for the most part getting oxygen into the blood, which is the issue. And there can be a couple of different reasons for that. All right, so this is a lot, but actually this is all really important to know. So the 5 causes of hypoxemia is what we're going to focus on for the rest of this section. High altitude, hypoventilation. Notice that these are red arrows. These are the normal AA gradients. Everything else is a blue arrow, which is a larger AA gradient. So VQ mismatch, if anybody asks, this is the most common type form of hypoxemia, and that's because there's so many different types or causes. You can consider pulmonary embolism, these are all causes of hypoxemia, or excuse me, of hypoxemia, specifically VQ mismatch hypoxemia. So specifically, this is a dead space. Now, arguably under the realm of VQ mismatch is a shunt as well, just in the other direction. So a VQ of infinity is dead space, a VQ of 0 is going to be a shunt. But for the most part, VQ mismatch just is talking about things that are more or less, in the middle 90%. So things on the far extremes are going to be called dead space and shunts. Shunts are such common forms of hypoxemia, not as common as a VQ mismatch, but they're also so important because they are the only ones that do not respond to oxygen that we consider them their own category. This is the fourth category. Foreign body aspiration, AV malformation, patent foraminovalia or atrial septal defect. Or notice that pneumonia and pulmonary edema can show up a couple different places. They can show up over here, which we'll talk about. They can also show up here if it gets particularly severe. So the idea is the difference being that a little bit of air getting in versus absolutely no air getting in, to the point where you cannot compensate with hypoxic vasoconstriction. Obstructive lung disease as well, COPD and asthma. And lastly, we have the diffusion limited hypoxemia. This is usually not a large issue unless somebody exercises. And then this is where you notice the diffusion issue. In other words, someone who has a diffusion limitation, like scarring the alveoli, they might have normal oxygen levels until they start exercising, and then they become hypoxemic. So the surface area could go down with emphysema, which affects diffusion, or the thickness of the membrane or the wall could go up due to ARDS, fibrosis, etc. Of course, you can have more than one of these at the same time, right? Think about it who's up in the mountains and they're smoking and they have MG and they contract pneumonia, and all of these different pathologies are going to collaborate to, cause a bad time. So common responses, well, if we have less oxygen coming in, that usually means we have more CO2 in our alveoli. And remember, our shortcut heuristic is that CO2 and O2 are mortal enemies. So if CO2 is up, O2 is going to go down. So one response would be to hyperventilate. This helps us get rid of extra CO2. And of course, this won't always happen, right? As an example, you're probably not going to hyperventilate if you have some sort of, I didn't actually mention these. Obesity, opioids, scoliosis or ankylosing spondylitis or ALS, myasthenia gravis, or Lambert-Eaton myasthenia syndrome. So in a hypoventilation system, you might not hyperventilate if you can't, but often a response will be to hyperventilate. Now that we get rid of more CO2, maybe we're also bringing more oxygen at the same time, but there's also more room for the oxygen now that the CO2 is out of the picture. This will cause a hyperventilate to get rid of the CO2. So if this goes down, this should actually cause a higher pH, in alkalosis. Due to the Le Chatelier shift once we get rid of the CO2. And more importantly, probably, is the vasodilation. So if a particular alveoli is not getting a lot of oxygen, vasoconstriction is going to occur. So normally, tissues, when they want more oxygen, they vasodilate to increase blood flow. The lungs are the exception. If you think about it, it makes sense. It's because they're trying to get... we want to be sensible with where we allocate blood flow. And if an alveoli stinks, let's shunt it away to a better alveoli where it can't get oxygenated. Over time, this constriction can lead to hypertension and core pulmonale, right-sided heart failure, which is going to cause lower levels of edema, ascites, jugular venous distension, etc. All right, so number one cause of hypoxemia, not just number one and arbitrarily how I numbered it. Remember, the VQ mismatch is the most common. As you go up, as we saw earlier, there's less atmospheric pressure. There is, it's still 21% oxygen, but there's just less particles in general. So this is normally our equation, but our equation sort of becomes this. So this value becomes lower, and if that value becomes lower, the alveolar oxygen content becomes lower. Having said that, you can still equilibrate with the capillaries perfectly fine. So that's why we have a normal AA gradient. So in other words, it's a 70 because we have trouble getting oxygen in. Why? Because there's no oxygen in the atmosphere. But you can diffuse perfectly fine. Notice this is PaO2. So, 70 would be 70 once it equilibrates. But remember that the bronchial vein might dilute it a little bit. And so maybe it'll be something like 60. Adaptations of high altitude, more EPO, it means more red blood cells. and 2,3 BPG to stabilize the tense conformation. Remember, earlier we had that 38%, but when you're at a high altitude, now it's maybe 30%, but with a right shift, you can get it to be 37%. So sure, you pick up a tiny bit less oxygen, but that's compensated by the fact that you're offloading way more oxygen. The hemoglobin is not binding as tightly in the tissues, which is what we want. This is just a fun little picture. So 40 and 40, but now it's 70 because you have not a lot of oxygen in the atmosphere. And this should say, just for the rest of these pictures, this should say vein, this should say vein, this should say capillary, this should say capillary, and everything else is correct. This is the artery. I guess this is technically the pulmonary, oh my gosh, yeah, this is the pulmonary vein, pulmonary, oh gosh. So this is the pulmonary vein oxygen content, while as this is just the venous oxygen content. I mean, you guys should know what this is, but I just really want to spell it out. So venous, capillary, and then over here we're going to have the pulmonary vein. And then over here, this is correct. This is the pulmonary artery. So we're at 40. We should perfectly equilibrate to 70 because there's no issue with diffusion. But and so now the pulmonary vein has 70, but the bronchial vein dilutes it. And so now, the rest of the pulmonary vein, which is going to go through the left side of the heart and now go into the systemic arteries, this PA is going to be 60. So just we're going to see a bunch of these same pictures, so make sure that that's very clear. AA gradient is fine, and yet we have a low PaO2. By the way, don't take these numbers too seriously. I just made up all of these numbers just to illustrate the point. I think they're pretty good, but just don't obsess too much about anything. All right, hypoventilation, opioids, obesity, the neuromuscular issues like myasthenia gravis that we talked about. Could be a low tidal volume or a low respiratory rate. And so here the idea might be that, one, you're bringing in not enough oxygen because your breaths are very shallow, or the frequency is too low. But again, think that if you're not breathing, you're also not getting a lot of CO2 out. Not a lot of CO2 going out, and remember they're mortal enemies, means that less oxygen will come in. It's crowding the alveoli. So again, weight, drugs, and something like ALS. And this is pretty much the exact same picture. 70, why? Because maybe the CO2 is up because we're not getting enough out, or we're just not bringing enough oxygen in, period. But it's equilibrating fine. This is just like high altitude. So this is the capillaries, this is the pulmonary vein, and then once we're getting past the heart and we're getting into the the systemic arteries, which is about 60. Again, our AA gradient is fine. Now, all of the AA gradients are going to be screwed up after this. So VQ mismatch. First of all, what is VQ? V is the ventilation, the amount of air that makes it to that part of the lungs, that part of the alveoli. Q is flow. This is perfusion. This is blood making it there. In an ideal world, it's a 1-to-1 ratio. But fortunately, it's normally 0.08, unfortunately. Now, gravity plays a role here. Gravity is going to bring more blood and more air to the lower lobes. Having said that, gravity is going to affect blood more than it affects air. So much more blood goes here compared to how much air goes here that overall you have a low VQ in the lower lobes. And there you have the opposite problem. You have a higher VQ in the upper lobes. So it's about 3 in the upper lobes and about 0.6 in the lower lobes. The pathological consequences of this is that tuberculosis is likely to reside in the upper lobe. Why? Because tuberculosis is anaerobic. Also, it's harder for leukocytes to travel through the blood to get to the upper lobes if, as we just said, gravity pushes more blood down. So it's also a little bit safer from the immune system. And at the bottom, again, gravity, so more blood and gravity in general. So any clots are more likely to go to the lower lungs than the upper lungs. We've mentioned before there's a dual blood supply because of the bronchial artery, so it's a little bit refractory to, it's kind of like a filtration system for blood clots. The VQ spectrum, as I said, this kind of like 90% territory. It's kind of like nucleophile and base and gen chem. Like there's a strict denotation, but then there's also a connotation. So VQ mismatch, I suppose, technically encompasses everything. However, I think usually when it's used, people are using it in this like 90% region. So, this 90% is encompassing all of this. So at the extreme ends, we stop calling it a VQ mismatch. We call it dead space. We call it a shunt. So if the VQ ratio is infinity, that's a dead space. The issue there is you're not getting any blood. This could be a pulmonary embolism. The trachea is also considered dead space, right? Because there's a lot of gas going through my trachea, but I don't really have capillaries wrapped around it that are participating in gas exchange. The shunt, on the other hand, you have perfectly fine blood flow, but it's just not going around any alveoli. Easy ways to think of this is a patent foramen ovale. So blood is going from the right atrium to the left atrium. In that case, it is not getting oxygenated, but the blood is flowing fine. An AV malformation as well, or just completely plugging up a whole bunch of alveoli. So these extremes would be the shunt. Again, the average is about 0.8. So usually a VQ mismatch as well, it's not going to be a global phenomena. On one part of the lungs, you're going to have maybe a low or high, and then that's going to somehow affect the other. So there's going to be some sort of compensation. So a VQ being low in one area might cause the next VQ to be a little bit high. Again, these are all causes of a VQ mismatch. So let's look at an initial scenario. So maybe this alveoli stinks. We're not getting enough ventilation, not enough oxygen in. And diffusion, though, is fine. So this is a value of 60. You know what? I'm going to change this color. All right. So this is a value of 60. And this one is a fine alveoli, and so it's 100 and 100, and that's great. Well, there's going to be compensation, right? Maybe someone will hyperventilate, but more importantly, hypoxic vasoconstriction. So hypoxic vasoconstriction, again, look what happens. I'm not having enough. This is a low oxygen here, so I constrict this, which means we're diverting blood flow over here. And now we can see that there. Less blood goes up here, more blood goes down here. So this is still going to be 60, but there's less, but previously it was like 100 milliliters in capillary. Maybe now it's like 50 milliliters. And maybe now this is like 150 milliliters. Now, there is a problem. Like, we want more blood flow to go to this one because this is the functional alveoli. But previously, oxygen was perfusion limited. I mean, it fully equilibrates during diffusion. It has no problem. It takes like a third of the way through the capillary, it reaches equilibrium. But if there's so much more blood flow going here, it might have a hard time doing that. So now the 100 doesn't perfectly match over here. This might now be like 95. So now when these mix, am I just bad at math? Is 95 and 60, 85? No, but again, this is more blood. So it's not a 50-50 split. Maybe 80% of the number is going to be from the bottom one. So the new pulmonary vein value, again, this is a typo, pulmonary vein value is 85. It then gets diluted, and now the systemic arterial pressure is going to be 75. So AA gradient could be 25, and it is going to be an increased AA gradient. Again, I made up these numbers, but I think that they're largely illustrative. If you look at the VQ mismatch, just notice that there was a VQ mismatch over here. This is all before. After we compensated, maybe this VQ mismatch is fine, but now this other one is a mismatch. So VQ mismatch in one part of the region, one part of the lungs will cause a different type of VQ mismatch, maybe in a different part of the lungs. So what if the VQ goes in the other direction? So we have a particularly high VQ. So this could be a mild occlusion or an extreme occlusion, right? A saddle embolism versus a smaller clot in the lungs. But when it's a 100% occlusion of a capillary, this is called dead space. Again, we said that trachea is technically dead space as well. There's a lot of ventilation with no perfusion. And we say that the VQ is infinity. And even more exaggerated than before, no blood can even get past here. It can't. So it's going to, rebound off of this, and it's going to be diverted in this particular direction. So previously we had 195, but now it's 190 because it's even more blood. It's even more, it's diffusion limited. There's just so much blood that it can't fully equilibrate as the blood is whooshing past, right? The blood's going really quickly through here. So it's trying to equilibrate, oh, nope, sorry, it already went all the way through. Now it's 80. That is an increased AA gradient. So determine a physiological dead space. A way to think through this is just imagine that during a tidal volume, you get rid of all of the lungs, all of the, it's only 15% for tidal volume. It's like 500 milliliters or whatever. But just pretend you're getting rid of all of the gas from your body during a normal tidal volume. And this will make a little bit more sense. So during the percent dead space. So the CO2, the left after exhalation, divided by the CO2 before exhalation. So again, we're assuming, like, just pretend that you would normally get all of the CO2 out. So if the value was 1, that means the CO2 left after exhalation is the same as the total CO2 before exhalation, which means you didn't get rid of any CO2, which means you had a lot of CO2 in your lungs and then none was, exhaled, which means 100% of your respiratory tree is dead space. You're not having any of that CO2 go, from the pulmonary capillaries into the alveoli and then out. So it's 100% dead space. So that would, obviously, this is made up. This is an extreme. It can never happen, but that's what 1B. If it would be 0, that means there was no CO2 left after exhalation. You completely got rid of all of it. There was perfect gas exchange. All of the CO2 from your blood got into the alveoli and then it was breathed out. So how to calculate this? The CO2 left after exhalation? Well, this is just the original amount of CO2 minus the exhaled amount of CO2. The original amount of CO2 is just the PA CO2. And then the amount exhaled is the expired CO2. Again, the reason that this is what it is because the alveolar is the same as the arterial. So the percent dead space can be said to be the dead space volume divided by the tidal volume. Again, assuming just that we're getting everything out in one breath, for me, is the easiest way to think about it. So the CO2 left after exhalation is the arterial CO2 minus the expired CO2 divided by just the total arterial CO2. So in other words, if the PCO2 is 40 and the expired is 30, 30 minus 40 over 40 is 25%. So 25% of our lungs would be dead space in this example. So now if a tidal breath was 500 milliliters, then 125 milliliters of it is wasted on dead space, whether this is anatomic or just a severe, VQ, pulmonary embolism type mismatch. You can use this to calculate alveolar ventilation. So the volume of air reaching the alveoli, well, this should be the total volume minus the amount of dead space volume. So if we use the above numbers, if I have 375, I would have 375 milliliters reaching the alveoli. Remember, there was 500 milliliters total. We said 25% of it was wasted, so 375 in one breath should reach the alveoli. Sometimes they want this per minute. Well, then it's like, all right, we'll just multiply by the respiratory rate. If I have 10 breaths per minute, then it would be 3.75 liters reaching the alveoli per minute. All right, if we look at the extreme on the other side of the VQ, we have a shunt. So here, the blood flow is completely fine. It just can't reach the alveoli for whatever reason. So I like to think of an atrial septal defect, a PFO. It could be an AV malformation. So AV malformation where the veins just prematurely, might form like a fistula or whatever with the arteries. PFO, which just jumps right through this foraminal valley or just some hole in your atria. But it could be other things like severe pneumonia, ARDS, things like that. I find it easiest to conceptualize by just thinking of the something like a PFO or an AV malformation. So if I think these VQ low, I think these are, ignore that. All right, so we're just looking here. In this case, maybe this is like a PFO. I have blood flowing fine. And I think a characteristic of shunt is that hypoxic vasoconstriction doesn't really compensate in these cases. So it's not even going to the lungs if I have like a PFO. So the blood is flowing fine, but it is, this actually should be 40 still. PaO2 is 40. So the blood is flowing through fine, but because maybe there's like, I have a foreign body, a hot dog stuck in here, no oxygen's getting in there, or maybe again, we can consider this a PFO. So like what I'm trying to show here is that we're not even going by the alveoli, so there is no diffusion. It's just the value is going to stay 40. And this is a completely normal one. And so when these mix, maybe this is 50. It depends if there was more of this than there was of this, like the numbers. I think the 50 was also when I thought it was 0. So maybe it'll be something more like, we'll change this on the fly. This should be something like 60, and then this can be something like 40, and then 100 minus 50 is going to be 50. So pretty dang close. So our value is 50, and tremendous AA gradient. So for shunts or dead space, so this is all normal. We should be familiar with this. Alveolar oxygen is 100. Alveolar CO2 is 40. Arterial oxygen should be about 100, maybe 95 once we consider that the bronchial vein dilutes it a little bit. PaCO2 should be about 40. Okay, well now think if we have a PFO. So if I have a PFO, again, the VQ is going to be 0. Why is the VQ 0? Because you have perfectly good ventilation, but you have, let's say our ventilation is 7, made up that number. It's 7, but my Q is going to be, you know, or actually, no, sorry, the ventilation is, yeah, maybe we have like something stuck in here. So there's going to be like no air. There's no ventilation of this blood vessel, while the flow is going to be perfectly fine. So this could be 1,000, and this is going to be about 0. So why is the PaO2 0? So now I think of like a, again, like a PFO. No blood is going anywhere near an alveoli. So there is no alveolar oxygen to talk about. There is no alveolar CO2 to talk about. And if there's no exchange, then, well, the arterial oxygen and the arterial CO2 should be the same as they were for the venous CO2 and the venous O2. On the other hand, we have like a dead space. So if I have like a clot or something, so now I'm going to have perfectly, so this is where I should say that there's a perfectly fine amount of ventilation that's coming in. Maybe it's 7. It's divided by the flow. Well, there's basically no flow, 0.0001 or 0.0000, you know, et cetera, 1. This is effectively a really large number. We can just call it infinity. So the PaO2 should be 150. Why? Because the reason it's not 150 is because some of it gets consumed. Some of it gets taken out of the alveoli, or we can think of it as competing with the CO2 for space. But there is no CO2 getting in here, period, because it can't get past this blockage. So this is just straight up what the inspired oxygen content is once we take into account the humidified air, subtracting it from 160 to 150. And then none of the CO2 can get into the alveoli, so it should be 60. Why are the arterial values? So the arterial values, we can imagine arterial here meaning that you have this as a systemic thing, or you can just think of the pulmonary veins when you're talking about these two values right here. They should be nothing. So in other words, if I'm talking about right here, nothing's getting through. So there shouldn't even be a number to talk about for here and for here. Diffusion limitation. So we have this great formula. Diffusion relates to the pressure, the surface area, the solubility, the distance, and the molecular weight. So a larger area, better diffusion. Larger thickness, diffusion is harder. It's got to get through all of this extra crap over here. A molecular weight, we know that O2 and CO2 diffuse well. Larger things don't diffuse as well. They don't get through the membranes as well. So higher molecular weight means I should have a lower diffusion. Higher solubility means it can get through and get into the blood more easily, so that's going to increase diffusion. And a stronger pressure gradient is also going to push things through. That's going to increase diffusion. All of these are perfectly mirrored in that formula. So relevant changes in variables, if you do scuba, nitrogen, or helium, maybe oxygen, but probably nitrogen is going to increase. Low ventilation could affect this. Supplemental oxygen definitely is going to increase the pressure of oxygen and affect the diffusion. Emphysema lowers the surface area, that screws up diffusion. Interstitial fibrosis is going to increase the barrier thickness, that's going to slow diffusion. CO2 is more soluble than oxygen, so it will be affected. You know, it diffuses more easily, so it's defected later. Oxygen would be defected before, so we're usually not going to even worry about CO2 as an issue there. And then exercise usually doesn't affect diffusion. Like you usually find it diffusing. Like even a third the way through the capillary of the alveoli, we diffuse all of, equilibrate all of gases. But if you have an issue, then the exercise is going to exacerbate that issue. So again, normally things are perfusion limited. We have 100 milliliters of capillary gas and maybe 3.5 liters of alveolar gas. And so the capillary gas is going to completely bend towards the alveolar gas. The alveolar gas isn't going to change much. Remember, that's like having 3.5 liters of 100 degrees Celsius water and 100 milliliters of like 20 degrees Celsius water. The 100 degrees Celsius water is barely going to change its temperature at all. While the other one will completely reach thermal equilibrium of about 100. So all of this to say is that blood is normally the limiting factor. So oxygen, CO2, they're great. They very quickly, like a third the way through, are going to equilibrate and match the alveolar concentration. Now, if you have a fibrosis, then diffusion is more difficult, and oxygen being 25 times less soluble than CO2 will be affected before the CO2 is, especially if you're exercising. In general, carbon monoxide stinks at diffusing, so with or without fibrosis or exercise, it's going to have a really hard time diffusing through. So it is going to be a diffusion limited. So during exercise, we're smooth muscle of our vessels are contracting and pumping blood through at an increased rate. Skeletal muscles are pumping it through our veins. Our heart's pumping faster. So blood runs through much more quickly. That leaves it less time to equilibrate. And again, if you already have a diffusion issue on top of that, then you very well might see an inadequate equilibration. So we would flip over from perfusion limited to diffusion limited, like I see from here to here. Now, as far as what would happen to the oxygen and CO2 values in the blood, well, remember that everything that we really see in the arterial side usually has to do with what happens in the alveoli. The alveoli kind of resets everything. But if I'm exercising, I'm consuming a lot of oxygen. I'm generating a lot of CO2. So though the arterial values might be the same, the venous values are going to be different. I'm going to have a lower oxygen value and a higher CO2 value. And so just looking at this, I have a fine amount of oxygen there. I have a fine amount of oxygen there, but maybe I have, maybe I took too much busulfan or bleomycin, or I had radiation of a lung cancer, and so that scarred everything and became fibrotic. So this is going to be a very, very thick barrier, and it's difficult for this 100 to get through. So it is diffusion limited, only maybe a little bit of it gets through. So now it's 70. It's 70, it gets diluted again, that's 60. I don't know why it says 66. The AA gradient has increased, it's 40. Again, AA gradient increases for everything except high altitude and ventilation issues. All right, so long story short, just remember that everything responds to oxygen except for shunts. Now let's see why, let's see how this plays out. So at a high altitude, remember everything is the same except instead of 760, this is going to be 400. For hypoventilation, I guess you're just getting less oxygen in, or you can think of the arterial, in other words, the alveolar CO2 values being the same. That is to say that at the end of the day, you're going to have a low oxygen concentration. So we've already talked about that. How does supplemental oxygen help? It can increase this from 70 to 100 by increasing the FiO2, the fraction. Instead of 21%, maybe it's a 100% or 50% or some other higher percent. So great. At the end of the day, now we've increased our value. What about a VQ mismatch? Okay, well, this is 60 and this was 100. Notice that I've already taken the hypoxic vasoconstriction into account. Here's a value of 75. All right, so this one goes to 120. This one might go to 90. They both went up a little bit. This one does not have a problem with diffusion, so that becomes 90. This one becomes 115, right? It doesn't diffuse perfectly because there's so much blood volume, but it diffuses pretty well, so it's 115. Now, notice these values, 85 to 91, they increased. It did get better, but where was the increase? Does this help as much as this one helped? And the answer is no. The top one actually, the extra oxygen coming in here was much more important than the extra oxygen coming in here. Why? Remember that PO2 is simply like an indirect tracker of hemoglobin saturation. And at the end of the day, dissolved O2, which is what contributes to the pressure, is a really teeny tiny amount of the total O2. Most of the O2 has to do with the hemoglobin. Above a value of 100 for your arterial oxygen value, your hemoglobin starts to be about 100% saturated. So maybe it went from 95% to 98% when I increased it from 100 to 120. But that's not really a big difference. That's a 3% difference in the hemoglobin, so it doesn't really matter. On the other hand, if I look at this top one, here we went from, I think, like 60 to 90. So now we went from like 75% hemoglobin saturation to 85% hemoglobin saturation. That's really what I care about, is I care about the fact that my hemoglobin saturation went up significantly. Yes, this tracks that, but this, at the end of the day, is the real hero. That's really what we care about. So we did not have equal gains in the top alveoli versus the bottom alveoli. Now, that wasn't really, really important there, but it's going to come up in a hot second with something else that we're going to talk about. So a VQ mismatch with a high VQ, infinite dead space. In other words, we have a pulmonary embolism. Let's see what would happen. So 100% O2, maybe this one would increase a little bit, but it's not diffusing anyway, so who cares? So this goes from 100 to 120, but remember, there was so much friggin' volume here that it had really had a hard time getting through. So maybe 120 makes this 100, which is going to fix everything. So again, we already kind of know the answer. Oxygen is going to help everything except for the shunt. I'm just trying to explain and tease out the logic behind it. So now the shunt, why does it not help with the shunt? Again, there's no compensation. The hypoxic vasoconstriction is not helping. We can imagine that this is like a, this would be like a foreign body aspiration. Maybe this is like a PFO or a AV malformation. Let's use that. So if I go from 100 to 150, yeah. So again, I probably should have changed the previous one. Who cares? So this is 180. That doesn't help this at all in the slightest. And this goes from 100 to 120. But remember what we said. Above 100, you're just increasing the dissolved oxygen content. You're not actually allowing the hemoglobin. The hemoglobin is already about as saturated as it can be. There's severe diminishing returns. So maybe 95 to 98 or 95 to 90%. It doesn't matter. We're mixing that with 0%. And so we get 49% at the end of the day, which is going to be a low PaO2. And I guess it helped to, we went from 95 to 98, but it basically didn't do anything. So hopefully that makes sense. At the end of the day, shunts do not improve with oxygen. Very important. And then the last one, diffusion limited. So this is 100 and this is 70. But if you remember the formula, diffusion is directly proportional to the pressure. So for whatever reason, low surface area or high membrane thickness is slowing down my diffusion, maybe that can be offset by a really, really, really high pressure differential. And that is going to push more oxygen through so that maybe this is still 100. And hooray, hurrah, we've now fixed it. So oxygen helps this as well. All right, we're going to do a quick overview of obstructive versus restrictive lung pathologies. To understand that, we really have to understand lung volumes and different lung capacities. We're going to look at spirometry, specifically an emphasis on vital capacity, functional residual capacity, forced expiratory volume, and then take a look at compliance curves. So lung diseases, you can think of this equivalent to cardiomyopathies with the heart. So obstructive lung diseases have difficulty getting air out. So COPD encompasses emphysema and bronchitis. Then we have asthma and then bronchiectasis. For restrictive lung diseases, the difficulty is getting air in. So we can break these down into mechanical issues. So hypoventilation, whether that be a reduced tidal volume or reduced respiratory rate. So muscular issues, whether it be polio, myasthenia gravis, or Lambert-Eaton myasthenia syndrome, Guillain-Barré. Then we have structural issues like ankylosing spondylitis, scoliosis, obesity. Interstitial is probably a little bit more common, especially for your NBMEs. So this is largely going to result in fibrosis, which is going to cause a diffusion limitation. Remember that the distance of the membrane was one of the factors for the diffusion rate. Idiopathic pulmonary fibrosis is sort of a shrug of the shoulders. Just fibrosis happens as you get older for whatever reason. Sarcoidosis, drug toxicity, largely chemotherapies, busulfan and bleomycin. Then we have hypersensitive pneumonitis. And then the pneumoconioses, which are really just when people inhale different types of dust. Asbestosis, barrielosis, silicosis, and then coal workers pneumoconiosis, which is really just the name of the overall category here. So like we said, obstructive, trouble getting air out. The alveoli, the lungs are going to swell, increased residual velocity, or increased residual volume, especially increased total lung capacity. COPD, which encompasses emphysema, bronchitis. Again, bronchiectasis is going to be an issue. Asthma is going to be an issue. For restrictive lung disease, like we just said, difficulty getting air in. So you're going to have shrunken lungs, the opposite problem, difficulty contracting. So the lungs have a hard time filling and getting air out. Anything ending in osis, the osis like sarcoidosis and fibrosis, are largely going to be restrictive in nature. So lung volumes, residual volume. So let's actually just start here. This is sort of our normal, this is where we live. We live in a tidal volume. So this is a normal inhalation, that's a normal exhalation, normal inhalation, normal exhalation. If I take in the biggest possible breath I can, we have our inspiratory reserve volume, IRV. If I take the biggest possible breath out, that's the expiratory reserve volume. Even after I blow off as much air as I possibly can, we still have some air left over in our lungs all the time, largely to prevent collapse. This is the residual volume. So this is everything we just saw. Inspiratory reserve volume, expiratory reserve volume, tidal volume is where we're going to normally operate, and then the residual volume. So the capacities are really just combinations of these. So the residual volume plus the ERV is the FRC, we talked about this. This is where PVR is a minimum and where the elastic recoil of the lungs inwards is going to be offset by the thoracic pull of the lungs outwards, because the intrapleural pressure is -5, which is, maintaining this nice equilibrium. It's also where the intraalveolar, intrapulmonary pressure is 0 in terms of its relative pressure to atmosphere. Inspiratory capacity is going to just be tidal volume plus IRV. Vital capacity is going to be these three things added together: IRV, TV, and ERV. And then, of course, total lung capacity. We can splice this up a couple different ways. So really, just to hone in on that, total lung capacity is RV plus ERV plus TV plus IRV. But remember, FRC, which is really important for a bunch of different things, this is equal to the expiratory reserve volume plus the residual volume. If we combine these two, these 1 and 2 that we just saw, these formulas that we have, we can redefine the total lung capacity as the functional residual capacity, which is really just the ERV plus the RV, plus the tidal volume, plus the inspiratory reserve volume. Third, we have a vital capacity, can also be defined as the expiratory reserve volume plus the tidal volume plus the inspiratory reserve volume. So these three things together are going to be the vital capacity. So combining now formulas 1 and 3, total lung capacity can be defined as the residual volume plus the vital capacity. So spirometry, understanding these lung volumes and lung capacities, is going to be really helpful of distinguishing between obstructive and restrictive lung diseases. A flow volume loop, this is a common thing for a spirometry. So going in this particular direction is for exhalation, going in this particular direction is for inhalation, and the absolute value of the y-axis is going to talk about the flow, whether it's inhaling or exhaling. So if you're exhaling, exhale as hard as you can after taking the inspiratory reserve volume, the biggest breath you can. The peak flow is PEFR. FEV1 is I am blowing out for 1 whole second. That brings us to the forced expiratory volume 1. So it's probably going to come around here. If you're looking at something like this, this will be a tidal loop. So this is just maybe from like 3.5 liters to 3 liters to 3.5 liters to 3 liters. And then an inhalation is probably less significant, less focused. So again, like I said, this is after taking the largest possible breath you can. So, and at the same time, outputting the largest exhalation you can, which means that the difference between these two points on our curve is the forced vital capacity, also known as the vital capacity. So the total lung capacity here might be 6. This would be 0, no air, but of course we always have a little bit of air left in, so that's our residual volume. Another way of looking at this is just focusing on the rate of exhalation. So if we're looking at, this is starting here is the maximum. We've already taken the biggest possible breath we can, and now we're expiring, we're exhaling. So exhaling as much as you can up to 1 second, that is our FEV1. Notice we get most of the air out actually after a maximum exhale. So if you go for most of that right there, that was actually just really diminishing returns. Most of the air out gets out in the first second, and then the next 2, 3, 4, 5, 6 seconds or whatever, we're getting maybe 20% of the total air that we're going to get out. Keep in mind, you can't get all of the air out. So this maximum on this curve represents the forced vital capacity, because this is the maximum in and that's the maximum out. So this is my residual volume over here. Again, we saw the same thing over here. Total lung capacity down to functional vital capacity, and then the residual volume from here to whatever our 0 value is. FEV1 going to here, not to be confused with the peak expiratory flow rate. So this is really the bread and butter of this. This is the main thing to emphasize, that obstructive lung diseases, this is really just going to shift our spirometry loop to the left. Emphysema, we're going to have increased lung capacity, more air in the lungs. You're going to see this on a chest X-ray with increased radio translucency, especially an increased residual volume. I really want to emphasize that. Your TLC goes up, your FRC is up, all that goes up, but the RV goes up the most, because you can get air in, but you can't get it out. And any air that you can't get out counts as the residual volume. This increases the most of all. You're going to have a really hard time getting out. That's sort of how we define obstructive lung diseases. So your FEV1 and your peak flow, your PEVR, are going to go down especially. Now looking at the restrictive, we have trouble getting air in. Getting air out is not as much of an issue. Maybe an issue, but not as much of an issue. We have smaller residual volume, smaller total lung capacity, and a smaller functional residual capacity. Now notice we also do have a lower forced expiratory volume and a lower peak flow, but it's not as pronounced as we have it with the restrictive. Importantly, the vital capacity is down significantly. We can consider a restrictive a shift to the right. Also notice that for the obstructive, we have this little characteristic dip that you should be able to just sort of identify just by eyeballing it. So for the flow volume loops, for obstructive versus restrictive, again, this is focusing on rate. Let's consider a normal situation. So maximum breath in, we're here. After 1 second, we're here. After blowing as much air as we can out, we're now at the forced vital capacity, also known as the vital capacity. And this is our residual volume, which is whatever's left over. So for a normal situation, I take a big breath in and I'm taking as much as air as I can get out. In 1 second, I get 3.5 liters out. I keep blowing for another 4 or 5 seconds. I get 5 liters out in all. So the FEV1 to vital capacity or forced vital capacity ratio is normally around like 70% and 80%. Anything below 70% is going to be diagnostic for obstructive lung disease, and we'll see why in a second. So obstructive lung disease, yeah, sure, maybe our forced vital capacity goes down a little bit. And this might seem counterintuitive because we just said that the total lung capacity goes up. You would think the FVC goes up as well. In some cases it might, but the idea is that the main thing is more air is in the lungs, but it's air that you can't get out. You lose, the emphysema destroys all of your elastin. You have very little ability to exhale this air, so your vital capacity increasing is really the reason for the total lung capacity increasing. So your FVC might go down. That's not as important as the idea that you can't get air out. So really significantly, the FEV1 is what goes down the most. So we saw normally it was 3.5, maybe now it's 1.5. And even though the FVC might have gone down in this scenario, it doesn't matter. The ratio is really what we're concerned with. Now it's 37.5%, well below our 70% diagnostic of bronchiectasis, asthma, COPD, emphysema or bronchitis, anything like that. Now for a restrictive lung disease, notice that we kind of have the same problem. We might have trouble getting air out. I know that's not how we normally think of restrictive lung diseases, but nevertheless, that might be an issue. But more significant for restrictive lung diseases is we have a hard time getting air in. Less air in because they won't expand because of all of this fibrosis and whatnot, means that our total lung capacity or vital capacity, and yes, here our forced vital capacity are going to go down. So after the biggest possible breath, the most air you can get out is 2 liters. That is your vital capacity. That is very, 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 very low. So despite the fact that you have a low FEV1, the ratio actually kind of maintains itself at a 75%. They both go down, but again, the FEV1 might not go down, or might go down by an equal amount compared to the FVC. Compliance curves also change. So emphysema, we have no elastin. We can think of these as just big, stretchy, compliant things. So to get us to the total lung capacity, so the y-axis here is the lung volume, and the x-axis is the transpulmonary pressure, really just the amount of pressure needed to inflate the lungs. Looking at this first curve, the idea is that you do not need a lot of pressure to get to the maximum expansion with COPD. You need a normal amount for a non-pathological lungs, and very small amount if we're looking at fibrosis, any sort of interstitial lung, restrictive lung disease, pathology. Needed a ton of pressure to open up the lungs to this total lung capacity, despite the fact that the total lung capacity is a very small value. Obstructive lung diseases. Hard time getting air out, mainly. So COPD encompasses bronchitis and emphysema, and then bronchiectasis and asthma are the other 2 conditions. Here we go, as opposed to restrictive lung diseases, which is trouble getting air in. So if you have trouble getting air out, you're going to have more CO2 in your alveoli. It's going to leave less room for oxygen, so this might cause hypoxemia. This might be associated with a VQ mismatch. So if you have trouble getting air out, you're going to have a reduced forced expiratory volume. Now, even if your vital capacity goes down, the FEV1 is going to go down way, way, way more. Now, you do have an increased total lung capacity, but I would keep in mind that this is mainly because you have an incredibly increased residual volume. You have so much extra air in your lung that you can't get rid of. That's how we define residual volume. So this obstructive spirometry curve is going to push everything to the left. You get this little characteristic kink right there. Notice that our residual volume has increased. Our total volume has certainly increased as well. And the forced expiratory volume is going to be a little bit less than it would have otherwise been. We can also see this on this graph here. The FEV1 over, so here we're seeing that the FVC is about the same. So the FEV1 over FVC is less than 70% as the diagnostic. Even if the FVC changes a little bit, the FEV1 over FVC should be less than 70. On a chest x-ray, so you get this barrel chest, this increased anterior posterior diameter. You get this flattened, so this is a normal diaphragm. And notice we have this nice costophrenic angle. Here the costophrenic angle is a little bit less pronounced, and the diaphragm is surely a little bit flatter than it is over here. Additionally, we have this this radiotranslucency. Just look how black this is compared to this. Now, I know these are different x-rays and there's a bunch of different factors, but in general, this would be true that you'll have a whole bunch of dark here. Keep in mind, you might get this with a pneumothorax, but pneumothorax, if it's tension at least, might shift the entire thing to the right or the left. It also will usually be unilateral and not bilateral, in addition to the diaphragm and the barrel chest. So COPD, chronic obstructive pulmonary disease. So these are often going to coexist, bronchitis and emphysema. Caused by smoking is really the main culprit, pollution, but mainly smoking. Bronchitis is defined by its clinical features. Emphysema is defined by the structural changes in the alveoli. That this is what leads to the enlarged airspace. Because of the extra air in the lung, the extra total lung capacity, residual volume, if you bang on a drum, it makes a sound because of all of the air inside of it. So similarly, if you bang on somebody's lungs, it might make like a percussion sound, but if there's a lot of air, it'll make a louder. So it's hyper-resonant to percussion. It's caused by cigarettes. And again, bronchitis, we get mucus here. And emphysema, we have destruction of the alveoli. So emphysema means to inflate or to swell. And this is the destruction of, yes, the bronchioles, but mostly the alveoli. The elastin and the collagen are the main culprits. So if we have centri-acinar emphysema, that means the alveoli that are sort of the most proximal, the first ones that you'll see as you're moving through the respiratory tree. These are the ones that smoke would get into, right? The smoke isn't going to get into the early alveoli before it gets in the late alveoli. So this is induced by smoking. So it makes sense. It'd be the first before the latter. You have an inflammation immune response to the cigarette smoke. Immune cells come in, neutrophils, macrophages releases all of these proteases, elastases break down elastin, collagenases break down collagen, and this gives the alveoli their elasticity, and so this is now gone. Pan-acinar emphysema. So everyone has an enzyme or protein called alpha-1 antitrypsin. This is a protease inhibitor. It sort of pumps the brakes on proteases from just destroying everything. Some people have a genetic deficiency in this, so they're going to be particularly susceptible to any sort of lung damage. So if they smoke a cigarette, it might be the equivalent of 100 cigarettes of somebody else because this immune response proteases are hard to cut down on. So macrophages and neutrophils, their proteases will go unchecked. This is pan-acinar because it's not anything to do necessarily with the smoke getting into the first one, so that might exacerbate it. It's just going to be global. It's going to be a global phenomenon in the alveoli. Why the lung volume increases? The bronchiolar, they collapse, specifically because of the elastin. So the elastin here holds these things out. So as air moves through here, one of the properties of Bernoulli's principle is the higher the velocity, the higher the kinetic energy, and therefore the lower the pressure. So now I have a low pressure environment. This is going to therefore be high in pressure. This is going to want to cause a collapse. Elastin is normally what prevents this collapse, but you know what? If you got emphysema, you got no elastin, so the low pressure will go ahead and collapse these. If you collapse this, you trap air in here. This is air trapping, and this is one of the first reason. So emphysema, people sometimes called pink puffers, and this is because breathing with pursed lips is going to increase the intraalveolar pressure, which might be able to pop these bad boys open to allow air to get in and out. Another reason is that compliance increases. So the no elastin in the alveoli makes them more compliant, so air comes in and it causes them to swell much more than they normally would. Remember that when we're looking at the alveoli, something we saw earlier is that elastin causes them to collapse. Previously, we were worried about too much collapsing, but we're worried about the opposite problem too. If there's not enough collapsing pressure, there's going to be swelling too much. The volume is going to get too large. More air in and reduced ability to collapse and push it outwards, which is why the FEV1 goes down. Additionally, if you have this, swelling of the alveoli, that really breaks down the surface area. What you're supposed to have all of these different little septae that keep the alveoli separate. But you know what? If everything just swells, it kind of just becomes one big blob. This reduces the surface area. Like we said, the anterior posterior diameter increases, this barrel chest. You can see it there. And bronchitis. So bronchitis, like we said, is more clinical symptoms diagnosis. Wheezing and crackles, especially wheezing. A productive cough, so mucus. You need it for at least 3 months for a year for at least 2 years in a row. So this is just chronic inflammation, hypertrophy, hyperplasia of the mucosal glands and the bronchi, again, largely in response to smoking, and the mucus makes it difficult to get air out. Again, that's why this is obstructive. So the cigarettes cause, these irritants cause hypertrophy and hyperplasia of, so here, this is what a normal mucosal gland looks like. Notice they're kind of small. And now they're going to be a lot more hypertrophy and hyperplasia, bigger and more of them. In fact, you can use this as a diagnostic index. So this entire thing, so this is the mucosa and the submucosa, the epithelium, the goblet cells, pseudostratify, lamina propria, connective tissue, cartilage, etc. If you just take the mucosal glands and you divide this by the entire thickness of the wall, it should be less than 40%, right? This is well less than 40%. But if you have hypertrophy and hyperplasia from here to here, this now might be greater than 40%. Some people say greater than 50%. This is the Reed index. This can be diagnostic, although again, we typically use clinical features. This is kind of hard to measure. Bronchiectasis, so bronchi, ectasis is widening. This causes widening of the bronchi, specifically because we're going to be breaking down elastin and cartilage in the bronchi as opposed to the bronchioles. We saw the opposite effect there where it caused a collapse. They're going to get filled with so chronic infections. You're going to have chronic mucus in the bronchi. We're going to cause them to dilate, as we just said. And this chronic infection is usually facilitated by cystic fibrosis, Cartaginer syndrome, and again, smoking is going to be a big culprit. So swelling. And not just mucus, but pus as well. People are going to cough up, in fact, huge like cupfuls of pus. Kind of gross. Asthma, panting in Greek. Type 1 hypersensitive reaction. So an allergen could be pollen, but cigarette smoke, car exhaust dust, pet dander, cockroaches, aspirin. Dendritic cells are going to receive these antigens. They're going to present them. They're going to activate, Th2 helper cells. IL-5 recruits eosinophils. IL-4 recruits, B cells to convert to plasma cells, specifically to class switch into IgE. IgE coats mast cells. And now if I see that particular antigen again, there's going to be a hyper response, releasing histamines and leukotrienes, which causes tons of downstream responses. The eosinophils are responsible for the hyper responsiveness, the mucus, the scarring, and the mast cells are going to be responsible for the bronchoconstriction. So another picture, dendritic cells do Th2. Th2 has IL-5, make eosinophils in the bone marrow. These are then going to migrate out and cause damage, and this is going to cause mucus and hyper-responsiveness. On the other side of the Th2 is the IL-4. IL-4 class switches B cells to IgE. These coat the mast cells, which cross-link these antigens. This is going to release histamines, leukotrienes, which causes bronchoconstriction, narrowing the airway. Aspirin can also, in some cases, induce asthma. If you think about the arachidonic icosapent pathway, this arachidonic phospholipid can be converted by COX into prostaglandins and thromboxane. But if you take aspirin, it inhibits this, which means that all of the arachidonic acid is now going to be shuttled over to this alternative pathway, leukotrienes. Leukotrienes are going to facilitate proliferation of tissue in the upper respiratory epithelial in the nose, and it is going to cause potentially nasal polyps to develop, extra mucus, sinusitis, things like that. Methacholine, I mean, it's even the name, choline. It sounds like acetylcholine. It's an acetylcholine agonist. Acetylcholine is a parasympathetic nervous system neurotransmitter. Well, think about it. If you're resting, you don't need a lot of oxygen, so you can bronchoconstrict. But if I'm running from a parasympathetic, I need tons of oxygen, so that's going to be bronchodilation. So this is parasympathetic, which means it's going to induce bronchoconstriction. Why would we ever want to do this? Well, if we want to diagnose somebody with asthma, we can kind of stress test them. If you gave somebody who doesn't have asthma methacholine, it is going to reduce their FEV1. It's going to bronchoconstrict. But you're hyper responsive if you have asthma. So not only should you bronchoconstrict, you should super duper duper bronchoconstrict. And I should see a much larger drop in the FEV1 than we would normally have. Asthma is associated with histological findings, Kirschmann spirals, which is really just mucus, and Charcot-Leyden crystals, which are really just the eosinophils, which remember we get from the Th2 IL-5 production pathline. In contrast to obstructive lung diseases, restrictive lung diseases are characterized by difficulty getting air in. They can be separated into two major categories, those of mechanical issues and those of interstitial issues, mostly fibrosis of the lungs. So again, mechanical, so this is hypoventilation, whether respiratory rate or tidal volume, and then interstitial, which is usually a fibrotic diffusion limitation. So with the mechanical, we can really further separate these into two more categories, those of muscular issues, so polio, ALS, myasthenia gravis, Lambert-Eaton myasthenia syndrome, Guillain-Barre, and then for structural scoliosis, ankylosing spondylitis, and obesity, you should have a normal AA gradient. So chest expansion is limited. I mean, it's like imagine trying to take a breath with someone sitting in your chest. So again, whether it's either of these categories, this will lower your alveolar oxygen values and induce hypoxemia. We can also, we're kind of sliding this in, nocturnal mechanical hypoventilation. In other words, sleep apnea. So hypoventilation that occurs really just during sleep. So it's defined as a cessation of breathing for more than 10 seconds during sleep, a couple episodes a night. Obviously, somebody will be really tired. Nocturia, so going to the bathroom a lot, peeing when you're more than 2 episodes per night. Pulmonary hypertension due to the hypoxic vasoconstriction, but 2, the hypoxemia is going to induce hypoxia of the art. So coronary oxygenation is going to be limited, alterations to blood pressure. So yeah, tons of heart issues are associated with sleep apnea. 25% of men is very common in larger obese males. So notice here we have breathing, 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 flat, breathing, breathing, breathing. So this again has to be 10 seconds. Same thing here. This is really just obstructive versus central, which we'll talk about now. So obstructive is where you have literal tissue obstruction of the flow through the pharynx. So it's usually weight related. And then central, which is a little bit less common, is that the nervous system, usually due to some sort of maybe a stroke or opioids, is inappropriately monitoring ventilation rate in response to CO2 changes. So the central chemoreceptors are defective for whatever reason. So now getting into both of these categories. So everyone during sleep, actually, no, sorry, I guess now we're just talking about obstructive. Everyone during sleep is a combination of gravity and your muscles relax when you're sleeping because of hormonal changes. This allows the tongue, so normally air goes like this, but these changes cause the tongue and everything to, the muscles relax, and then the tongue, gravity pushes this downwards. So it's a little bit more difficult for air to get in. That is just regardless of whether you're the healthiest person on earth or not. Now, this can be exacerbated, this problem of air getting in, through one, allergies. So if allergies get in, they can inflame the airway, making it more difficult for air to flow through. Infection, so swelling of the adenoid or the tonsillar tissues. I had a girlfriend who's normal weight, very healthy, and she had swollen tonsils, and it was causing severe sleep apnea. She had her tonsils removed, and it 100% fixed the issue. Some people have an overbite. The overbite, so pushing of the jaw back, will actually cause it more difficult for air to get in. And then lastly is if you're obese, you have this larger neck, extra soft tissue, obesity related, makes it more difficult for air to flow in back there. The main one, though, being overweight. So obese males over 40 is going to be key for sleep apnea. Now, essential sleep apnea, CNS injury, opioids, also congestive heart failure, interestingly, can cause this. The brain can't properly calibrate CO2 levels, so it's constantly overcorrecting. So for whatever reason, your CO2 levels are normal. Maybe they get a little bit high, and if they get a little bit high, the chemoreceptors in your brain go, oh, CO2 is too high. Let's start hyperventilating. It hyperventilates, which is going to blow off all of your CO2. It blows off too much. Now that it's too low, your brain wants to correct in the other direction. So no apnea, a cessation of breathing or hypoventilation is going to now correct for this, and the CO2 levels are going to rise. Now let's just focus. From here to here, we're looking at this hyperventilation, right? Hyperventilation. And now from here to there, this apnea is, well, that's where the sleep apnea comes in. So again, this has to be 10 seconds. And now this pattern of hyperventilation with apnea, hyperventilation apnea is known as Cheyne-Stokes respiration. And the difference really between obstructive and central sleep apnea can somewhat be illustrated here. Notice, again, we have the 10 seconds no breathing, 10 seconds no breathing. But in this case here, there's no effort put in. I'm not seeing the chest and abdomen really move up and down. Here it is moving up and down, but it's just no air is getting through. So which one's which? This is going to be central sleep apnea, and this is going to be obstructive sleep apnea. Treatments, avoid depressants. So remember that gravity closes access from your pharynx into your larynx, but also the muscles relax as well due to hormonal changes. Well, depressants are just going to further relax the throat muscles, make it collapse even more. It's even more difficult for air to get in. Sleeping on the side is going to allow better airway into the lungs. CPAP, continuous positive airway pressure, forces the airway open. The problem here is that there's poor patient compliance. I think the mask is just kind of, I have a hard enough time wearing my mouth guard. I can't imagine wearing this every night. So poor patient compliance. Surgery, like my lady friend, to remove tonsils, adenoids, realign the jawbone if you have a overbite. And then oral mouthpieces as well can go ahead and move the jaw forward, which moves the tongue and a lot of these muscles forwards and this tissue forward so that the air can get in a little bit better. All right, so interstitial lung diseases. So this is just general hypoventilation. Or I should not actually know, getting outside of hypoventilation. This is just interstitial lung disease. So this is usually going to cause fibrosis, which limits diffusion. Usually microparticles get into your alveoli. Sometimes you have idiopathic pulmonary fibrosis, which is just for whatever reason you get old and things get fibrotic and crappy. But other than that, we have microparticles that can get in. And maybe this actually contributes to idiopathic, and it's just harder to point the finger at somebody. But macrophages, neutrophils will come up, release chemokines, more immune cells are going to come in. All of this stuff, as always, it damages the epithelium. Fibroblasts are going to come in and lay down extracellular matrix. Again, we have several different types: idiopathic, sarcoidosis, drug toxicity, bleomycin and busulfan, the chemotherapy drugs, hypersensitivity, pneumonitis, birds, pneumoconiosis, asbestos, berylliosis, silicosis, and coal-induced pneumoconiosis, which is really just the name, same name. So healthy alveoli diffusion is no problem. Fibrotic alveoli, again, in response to any of these things, it's just the distance is a little bit too large. And if we remember from our formula, that makes it difficult for gas to get through. So CO2 is 25 times more soluble, which means that because it's more soluble, diffusion is easier, but oxygen is a little bit more of an issue. So this is normal. This is going to be perfusion limited, but you know what? Now we have diffusion limited, especially if exercise is present. So with most of these interstitial lung diseases, you get reticular opacities. Reticular just means net-like. Sometimes these are also called honeycombing, and opaque really just means you can't see through it. So you can really kind of see the honeycombing, which is really just another name for the reticular opacities here. But you can kind of see it here as well. So really important just to be able to eyeball this on a chest x-ray or an axial MRI. Sarcoidosis, which is really the first of these, sarcoid flesh disorder. Just remember that you're going to have these papules on the back. A lot of people get erythema nodosum. So there's a lot of skin flesh related symptoms here. And in general, sarcoidosis is a system-wide disorder. However, it does have an emphasis on the lungs, especially we're going to have the hilar lymph nodes involved. So the dendritic cells get activated. Triggers not well understood by some pathogen. They migrate to the lymph nodes. They activate the immune system. Causes lots of symptoms, Bell's palsy, where the facial nerve is damaged. We get a drooping of the face, inflammation of the eye, and erythema nodosum, which we've talked about. Sarcoidosis findings. So often this affects young Black women disproportionately. So look for that in the vignette. Granulomas, specifically non-caseating granulomas. So granulomas are usually caseating or non-casing, which really just means necrotic or non-necrotic. So it's not a necrotic core. A necrotic core would be something like tuberculosis. This is really where we have like a cluster of lymphocytes surrounding epithelial cells and multinucleated giant cells, which are really just lymphocytes which have merged with macrophages and epithelial cells. And we have these, again, you have this honeycombing, this reticular opacities. What you can kind of see here, there's a little bit involvement of the hilar lymph nodes. You can see it a little bit more in this CT scan. And the reticular opacities, again, are really clear when you look at the axial MRIs. Paraneoplastic syndrome, so macrophages, which are present in the granulomas, possess 1-alpha hydroxylase. These are necessary to activate vitamin D. So here's the pathway. So they don't really create vitamin D, but they help create the activated functional form of it. This is going to increase your calcium levels. Also, ACE is going to be present. Interestingly, I don't think that this actually is really strongly associated with an increase in blood pressure. Maybe it's because we already have enough ACE, and that's not the rate-limiting component. But nevertheless, an increase in ACE is also symptomatic. Birds, that's really all I would know. You see hypersensitivity, pneumonitis, and birds, those go together. So pneumoconiosis, there's a couple different types. Types that affect the upper lobes and type that affects the lower lobe. So really this is breath dust. So any sort of dust that gets into the lungs can be considered a pneumoconiosis. Coal workers pneumoconiosis, so coal gets in, also known as the black lung. Silica, so people working in the silica mines, I think this is prevalent in areas in India. People do sandblasting here in the States, kind of like a pressure washing, but with sand, so it's even it's even better at getting off rust and stuff. By the way, interstitial really just means between things. So interstitial comes up a lot. So interstitial just means between sand particles, and here we mean between lung tissue. So it's not in the alveoli, it's in between the alveoli. Sorry, that's a side note. Back to this. So for the lower lobes, we have asbestos. Asbestos, we see this in roofing and insulation and plumbing, people who work in construction or shipyards, old houses especially. And so there's a lot of lawsuits for mesothelioma that I'm sure people, there's tons of jokes about them. You see them, all over the TV and the internet. And the question is, it's kind of interesting because asbestos is actually more associated with bronchogenic carcinoma than it increases the risk of mesothelioma. So what's going on? Well, first, bronchogenic carcinoma really just means any old lung cancer. It's just sort of an outdated term. So just lung cancer. So why aren't we getting lawsuits for lung cancer if it's more commonly linked to asbestos? Well, the reason is that many things cause lung cancer. So if someone gets lung cancer, it's hard to point the finger specifically at asbestos. However, pretty much only mesothelioma is associated with, or mesothelioma is really only caused by asbestos. So if you got mesothelioma, it was probably from asbestos. So it's easier to pinpoint the finger at some organization you used to work for and initiate a lawsuit. There's about a 50-year latency for asbestos exposure. So if someone had exposure in the 70s, well, they're going to be getting mesothelioma about now. So even though they discovered the health risks and started getting rid of asbestos from housing insulation and whatnot in the 70s and 80s, well, again, it still takes 50 years for the cancer to kick in. So even though we stopped here, we're seeing the numbers rise. Eventually, they'll start to fall, but that would explain it, this time lag. Things to look out for, pleural plaques. You can see them here. You can especially see them on the axial MRI. You can see them here a little bit. And ferruginous bodies are dumbbell-shaped particles ingested by macrophages. Let's talk about pneumonia, ARDS, and effusions. So pneumonia really comes into a couple different types. So we're going to talk about lobar, broncho, and then interstitial or atypical. Just as often, and I think there's increasing pushes to sort of emphasize the recategorization of pneumonia in terms of whether it was community acquired or hospital acquired or ventilator, associated. We'll talk about exudate effusions, not transidate, and then a little bit about ARDS, acute respiratory disorder. So really just any infection of the lung parenchyma that's caused by microbes. This is going to bring in tons of fluid into the tissue. It can cause VQ mismatch. In extreme cases, it can be called a shunt. It can cause diffusion issues as well. But for pathogens to get in, they've got to bypass the cough reflex, the mucociliary escalator, and macrophages. So usual suspects: influenza, Streptococcus pneumonia, Haemophilus influenza, and Staphylococcus aureus. So like we mentioned, there can be a community-acquired pneumonia. There can be hospital-acquired nosocomial. This is going to be a little bit more serious, but, person probably has a weakened immune system already, so they're maybe a little bit more susceptible, a little bit more vulnerable. Also, the microbes are more likely to be resistant to antibiotics. Now, there's a subset. It's kind of funny because this is already in the hospital, but nevertheless, a subset is ventilator-associated pneumonia. So these people are probably really, really sick, so it's an extra large issue. They also can't cough, right? That's one of our defenses. We can cough and get the phlegm up, or we can spit it out or swallow it into our stomach where it's dissolved, but these people can't. So the old categorizations, we have bronchopneumonia, which is pneumonia throughout the entire lungs. Sometimes they can cause consolidation, which is really just exudate in the alveoli. Then we have atypical or interstitial. Sometimes this is called walking pneumonia, so it's a little bit more indolent. So it can kind of creep up on a person or maybe be benign, so this can be more infectious potentially. And again, interstitial just means that it's, like in between the grains of sand. It's in between our alveoli here. And then lobar pneumonia, where it's really just consolidated to one whole lung. And this does cause consolidation. So I keep using the word consolidation. What is that? This is where the alveoli become filled with fluid. Fluid is radio opaque instead of radio translucent. So notice this is the lobe here is now consolidated, right? It consolidated, it looks like one. So it's just really a radiological term. It looks like one solid unit, and that's because all of the fluid makes it appear as if it's one complete unit. I mean, there's still individual alveoli. That's the same, but it just looks on a chest x-ray. That's the only reason. So fremitus, the sound increases. Fremitus is the vibration created by a voice. And we see from, I don't know if they actually did this, but in cartoons and movies and stuff, Native Americans would put their ear to the ground to hear, horses or whatever coming. And the idea is that sound travels better travels better through the sound than it does through the air. And that is true, at least that latter part. And so sound will be louder if it goes through the the more solid fluid as opposed to the air. So fremitus increases. You get a most other percussion is going to decrease. If you bang on a drum, it's going to make more sound if it's filled with an air than if it's filled with fluid. And then you get bronchial breath sound. So bronchial breath sounds are normal if you hear them at the apex of the lung or the trachea. Bronchial breath sound is well, a normal vesicular breath sound heard at other parts of the lung and the periphery are going to be, I'm not doing it justice, but it's inhalation, quick exhalation. Inhalation, quick exhalation. For the vesicular, well, the bronchial is going to be an inhalation, pause, exhalation that are equal in length. Inhalation, pause, exhalation. So again, you're going to hear the bronchial sounds more often if someone has lobar pneumonia. So on the chest x-ray, bronchopneumonia is going to be, you're going to have these patches and it's going to be spread throughout the lung. Atypical pneumonia is it's going to look like interstitial fibrosis. It's honestly really difficult to tell apart. And in fact, they're both, so atypical is interstitial, but this is the same as interstitial fibrosis. So interstitial, they all kind of have these reticular-like opacities. There is a concentration in the hilar regions, though. But again, it's very difficult to tell apart. You probably need more information in the vignette. The lobar pneumonia is probably the easiest to tell. It's concentrated to a single lobe. People who are having trouble breathing, hyperventilation, that was one of our responses to hypoxemia. And pleuritic chest pain is going to be big. It's painful when they breathe. This is also going to be seen in tuberculosis and pulmonary embolism. So this pleurisy, this inflammation of the pleura, when they rub against one another, usually the pleural fluid reduces the friction, but because it's inflamed, they're going to rub against each other. It's going to be difficult when you take a breath. So looking at lobar, which is probably the most important one to know, S. pneumonia is going to be the main culprit here. So again, a consolidation, which is just exudate in the alveoli and the bronchioles. Again, this is dull to percussion, but it's hyper tactile for the vocal fremitus, so that increases. So this is normal. We now get an infection. The congestion for the first 2 days, it's kind of a red-purple. I'll put emphasis on purple because it's red in 2 phases. So there's some exudate at this point, as it makes sense, though, that this is mostly just bacteria because you just got infected. Your immune system has not mounted a response. After 3 to 4 days, we have what's called red hepatization. So now it's sort of a brownish color. Now the exudate has red blood cells, white blood cells, fibrin, bacteria. So clear signs of a proper immune response. The liver is going to look a little bit more solid and liver-like on the I guess it's gross morphology, but as well on the chest X-ray. And then we have the gray hepatization, where now the red blood cells are being broken down to the exudate, and that makes it look gray, and then the bacteria has been cleared out. And then a couple more weeks after that, the rest of the exudate is broken down, and it sort of gets back to normal. So again, the whole idea is that the consolidation is because it's filled with fluid. The fluid is an exudative fluid. It's filled with proteins. It's filled with leukocytes. It's filled with lots of cells and macrophages and all that good stuff, cytokines, proteases, you name it. So that is exudate. There is a leaky interstitium. That is how they're getting through. It's an inflammatory response. So that is, for the most part, reversible. They get filled with fluid, but it's reversible. This can progress if the immune response gets bad enough. This can cause an autocatalytic immune response called ARDS, acute respiratory distress syndrome. This is like the septic shock of the lungs. So it's really a lot of the same pieces of the puzzle. We have this inflammatory response, which causes the endothelium to become leaky. Fluid is going to rush in. The difference is that this one is a little bit less reversible, a little bit higher mortality rate, and often there's going to be a fibrosis and a destruction of the alveolar wall, replacing it with a hyaline membrane, which is just like dead cells, surfactant, and proteins kind of smushed together. And this is what it looks like on a histology. So it's usually, ARDS is usually an exacerbation, a continuation of pneumonia, but actually sepsis is even a little bit more common. So you can really just think of it as a non-cardiogenic pulmonary edema. Again, we also get fluid with just regular pneumonia that does not progress to ARDS. So the AA gradient goes up, whether we call this a VQ mismatch or in severe cases a shunt, or we just notice that it causes diffusion issues. We also are going to have an increased arterial oxygen pressure to inspired oxygen ratio. It's going to be less than 300. Honestly, I'm not sure why they do this. I don't know why we don't just say that the AA gradient is up, or even just say that the arterial oxygen value is down. Very important is this opaqueness, which is a little bit more homogeneous. It's blurry. It's kind of fuzzy. I really want to distinguish this from the atypical. Atypical, which looks like interstitial pulmonary fibrosis, again, has those reticular honeycombing opacities. This is just a big old cloud, and it's really, really important to pull out on a chest X-ray. ARDS, just like neonatal respiratory distress syndrome, can destroy the surfactants, destroys destroys the cell wall as well, but emphasis on the surfactant here, which can lead to alveolar collapse. So lung cancers of the parenchyma can be divided into 2 major categories. So small cell, also known as oat cell, and then we have the non-small cell, which includes adenocarcinoma, large cell carcinoma, squamous cell carcinoma, bronchial carcinoid carcinoma. Then we're going to have apex pancreas tumors, tumor of the pleura, mesothelioma, and then head and neck cancers can be thrown in here as well. So lung cancer, also known as bronchogenic carcinoma. Most common cause of cancer overall is breast cancer, and then prostate cancer, and then lung cancer. Again, this is overall. Now, when we look at the cancer deaths by type, lung cancer now takes the cake by far. And now, while it seems breast cancer and prostate cancer are not second and third, keep in mind this is overall. If you break it down by males and females, the second leading cause of cancer among women is breast cancer, and the second leading cause among cancer in men is going to be prostate cancer. And then close third would be colon cancer in both of these. So lung cancer is likely to metastasize from breast cancer, prostate, and GI. That kind of makes sense. Those are the most common types of cancer. Now, where will it metastasize to? It might go to the bone, to the brain, to the adrenal, and to the liver. I think of BBOW. Coin lesions are just something that you might want to look out for on a chest x-ray to diagnose cancer. It doesn't always mean cancer, but it's at least a good guess. Like we said, we can break this down into non-small, adeno, squamous, large cell, less commonly bronchial carcinoid tumors. There's also other types, but these are the main ones. And then O, also known as small cell. So men in general more than women. Now, I don't know if there might be many reasons for this, but a major one is that if you look at the proportion of smokers, it's historically been men. However, look at that, starting all the way back in 1920s, more and more women have started to smoke in terms of the total proportion of smokers. Largely due to things, like the women's right movement and oral contraceptive pills. We go from this like Pleasantville, Mrs. Beaver type woman. There's a cultural shift where women become, more get to go to school and more independent. And also there's all of these now tobacco ads that are targeting women. So that explains the rise. But this very much fits into the prevalence and the incidence of lung cancers. For men, it's been going down, coinciding with this drop in smoking, and here it's going up, coinciding with this rise in smoking. Most common cancer is adenocarcinoma, then squamous cell carcinoma. Probably the two ones to know, the adenocarcinoma here, and then the small lung cell. This is the worst, and it's paraneoplastic. The adenocarcinoma is noteworthy because it's non-smoking. It's one of the only cancers where smoking is not a major correlation in women more than men. I think of small cell, also known as oat cell, S for central. This is going to be centrally located near the hilar lymph nodes. It's the most aggressive one. And you have undifferentiated low-grade cells. These are neuroendocrine cells. So if it's neuroendocrine, I just think of something that's pushing in some sort of endocrine molecule through a synapse. So I think of the granules at the end of axons that hold on to these neurotransmitters and hormones. And the fact that it's a synapse, so chromogranin positive and synaptophysin positive. Produces ACTH, which is going to induce Cushing syndrome. Cushing is associated with hypertension and weight gain. Also, ADH, which is included by the symptom of inappropriate antidiuretic hormone associated with nausea and cramps. Also, weirdly, antibodies against presynaptic calcium channels. This is associated with Lambert-Eaton myasthenia syndrome, muscle aches, difficulty walking upstairs, lifting arms. As we saw earlier, this is a mechanical hypoventilation issue as well, potentially if it gets severe. And then the Kolchitsky cells with these very, very dark bluish nuclei. It's also MYC positive in addition to being chromogranin and synaptophysin positive. Adeno, I just think of saying no to drugs, no to cigarettes. So this is not cigarette associated, not tobacco associated, which is interesting. Also interesting, females more than males. Crass and epidermal growth factor receptor positive, and produces a lot of mucus, so it's mucin positive. And the adeno is for the gland, and this is mucus glands. Squamous cell, again, S for centrally located. Keratin pearls are going to be found here. I just think of the fact that, epithelial cells, squamous cells, produce a lot of keratin. This is something they're known for. So it sort of makes sense here. This is a keratin pearl. Also, they're going to be parathyroid hormone-related protein enriched. These are going to elevate calcium levels. Calcium also found in pearls. Pearls make calcium carbonate. So lots of calcium, and then you have these keratin pearls is going to be diagnostic. Large cell carcinoma. Main feature here is that the cells are largely variable. So they're undifferentiated, which means anaplastic, and pleomorphic, which means they vary in size. And just look at all of these, huge variety of sizes. And partly this is because these often come from giant cells, which are a fusion of macrophages, monocytes, and epithelial cells. So no wonder that they would be pleomorphic, coming from a fusion of such a wide variety of cell types. Bronchocarcinoid tumor, a non-small cell type of cancer, but it's not a super common one. Also neuroendocrine cells, so they have chromogranin. So tryptophan can be converted to serotonin by these particular neuroendocrine cells. This can be found in the urine as 5-HIAA, so that can help diagnose it. And too much serotonin in the body can induce carcinoid syndrome, which is, we'll see flushing and diarrhea and palpitations as major symptoms. Mesothelioma, so cancer of the pleura, highly linked with asbestos. Again, bronchogenic carcinoma, that is to say just lung cancers, are more linked, but lots of things cause lung cancer, so lawsuits make it difficult. Calretinin positive and cytokeratin positive. Ferruginous bodies are going to be found here. They're going to be macrophages. Also calcified pleural plaques when you look at imaging. You might get an exudative pleural effusion as well. And so here's these calcified pleural plaques. Pancoast tumor is going to be found at the apex of the lungs near the clavicle, so around the collarbone. This can compress a bunch of different structures, causes a wide variety of syndromes. So it can compress the recurrent laryngeal nerve, which can cause hoarseness. The stellate ganglion, which is associated with the sympathetic nervous system, can cause Horner syndrome. So this can cause anhydrosis, so inability to sweat. Ipsilateral ptosis, so a drooping of the eyelid, and an inability to dilate the pupils. The brachial plexus being compressed can cause sensory motor issues. The superior vena cava being compressed can cause superior vena cava syndrome, where if blood can't drain into the right atrium, you can imagine that it sort of builds up then in the upper part of the body. This is going to be associated with edema in the upper torso, and collateralized veins, and just a general cyanotic venous appearance to the torso and the body. Also, the phrenic nerve being compressed can cause the hemidiaphragm to be paralyzed on one side. So the phrenic nerve is needed to, when you contract your diaphragm, you pull it down. So this is normal and this is abnormal. See that it's pulled up on this side and not on this side, because here I have a Pancoast tumor. So I have trouble pulling the diaphragm down, which means it should be up instead. Head and neck cancer, almost entirely squamous cell, could be the nasal cavity, the nasopharynx, oropharynx, oral cavity. I mean, this is a largely variable type of cancer. It's associated with tobacco, alcohol, hot beverages, spicy foods, all the best things in life can damage this, and then the extracellular growth to repair this can, over time, contribute to cancer. HPV, typically associated with cervical cancer, has also been recently linked in increasing prevalence in society, the HPV-16 associated head and neck cancers. Let's talk about some tie-ins between the respiratory and circulatory system. So we'll talk about hypertension and edema, specifically transitate and exudate effusions, how these effusions can then also extend to the pleura. In addition, we have lymphatic effusions in the pleura, how deep vein thrombi can cause pulmonary embolisms. Then we'll talk a little bit about the nasal cavity, nosebleeds, and rhinosinusitis and things like that. So pulmonary hypertension can be defined as any sort of mean pulmonary arterial pressure greater than 25. So it's normally 14, systolic 24, 9 is diastole, leaning towards the diastolic side because that's about 2/3 of the entire contraction cycle. Ohm's law analog, the pressure in the pulmonary system is equal to the flow times the resistance. Well, the pressure is really just the pressure differential between the right ventricle and the left atrium. The right ventricle is really just approximating the pulmonary artery. The left atrial pressure can be measured by the pulmonary capillary wedge pressure. So putting a catheter in the pulmonary vein gives us the pressure there, and that's really just the pressure of the left atrium. So we can rewrite this as, just substituting the RV for PA, knowing that LA can be determined again by the pulmonary capillary wedge pressure, plugging in Puisseau's law and rearranging it, we get this nice equation. So this can show us that if you increase the left atrial pressure, you will cause pulmonary arterial hypertension. Well, that's probably the main way, right? The left atrial pressure builds up and left heart failure. Q goes up if I have increased cardiac output, and the radius will go down, which would increase the pulmonary arterial pressure. If I have any sort of hypoxemia, we talked about this, VQ mismatch, diffusion problems, shunts, things like that. BMPR2 is also a gene that normally inhibits vascular smooth muscle proliferation. So it's going to be associated with extra endothelium and less nitric oxide. So we have chronic vasoconstriction. This is just going to be a genetic predisposition to pulmonary hypertension. So left heart failure can lead to pulmonary hypertension, and then pulmonary hypertension can put too much stress on the right ventricle, which can lead to right heart failure, cor pulmonale. This is associated with ascites, hepatosplenomegaly, distended jugular veins, and peripheral edema. So the edema, though, that we're talking about in the lungs, not the lower extremity, but back to the pulmonary edema, cardiogenic. So if you had like heart failure, too much fluid means hydrostatic pressure is too large, or maybe you have cirrhosis or nephrotic system, so there's not enough proteins, not enough osmotic pressure. You're going to so this is normal, this is cardiogenic, and this is non-cardiogenic. So looking here, we're just going to push out water normally. Maybe a little bit of proteins, but mostly just water and fluids are going to get through. So I'm going to have a low protein content, less than 2.5 grams per deciliter. Now, we've talked about non-cardiogenic, things like pneumonia cause this, ARD cause this sepsis and malignancy. This is really very much just like your septic shock a little bit, right? So exudate is going to come out. So this is just increased capillary permeability. Proteins are going to get through. Fluid, of course, is going to get through. Leukocytes are going to get through, and the increased protein concentration is going to be somewhat diagnostic, greater than 2.9. It's going to be particularly cloudy, and because there's all of these proteins here, this runs the risk of infection here. So if you have an exudate effusion, it's got to be drained. There's something called Light's criteria for differentiating the transudate from the exudate. So effusion protein to serum protein ratio has to be greater than 0.5. So if it was cardiogenic, really just fluid would get through. So we can imagine that the ratio would be about 0 or 0.1, 0.2, pretty low. But now if you have really leaky capillaries, it's never going to be greater than 1 because you're not going to push out more proteins than fluids. But you'll push out fluids and you'll push out some proteins. But still, even with leaky, fluid is more likely to get out than protein. So it's going to be probably between 0.5 and 1 if it's an effusion. Lactate dehydrogenase, this is usually associated with damaged cells, which is, so lactate dehydrogenase is in cells, the cells are damaged, the LDH spills out. Exudative processes are going to damage cells. So it makes sense that I should see these go hand in hand. A serum, an effusion to serum ratio greater than 0.6 is diagnostic, or an effusion value that is greater than 2/3 of the upper limit of the laboratory reference range. And again, you can also just see the exudate is cloudy and the protein concentration is large, greater than 2.9. So these same effusions can also extend to the pleura, transudate, exudate, but also a lymphatic drainage known as a chylothorax, where something like the thoracic duct has been damaged and is spilling this milky, whitish, triglyceride-rich solution in that just builds up in the pleural space over time. So similar to cardiac tamponade, where you have filling of the pericardial sac, which presses on the heart, inhibits filling and inhibits contraction. Similarly, all of this buildup of pleural fluid can push on the lungs, can inhibit lung filling and expansion. If it gets too severe, it could even lead to atelectasis, so the lung collapse. But could also literally, cause cardiac tamponade to some extent. Here I have my heart in this mediastinum. If there's too much pressure, it could push into this and prevent the heart from filling and contracting. Pleural effusions are going to inflame the pericardium. This causes pleuritic chest pain, so pain upon inspiration, and it's going to be associated with a pericardial friction rub that can be heard upon auscultation. Gravity typically brings the pericardial effusions down. So this costophrenic angle is going to be completely blunted and abrogated. You can see it in axial MRI too, not to be confused with a pneumothorax, which should be radiotranslucent. This is radio-opaque. After treatment, we see that that goes down and that goes down as well. If somebody lays down, I suppose I could look, are they laying on their side? Are they laying on their back? It's going to affect how your, chest x-ray looks. Now, you need to drain this, especially if it's in the pleural space. So you're going to do thoracentesis. Make sure you go above the rib, because below the rib you have this neurovascular bundle, which you definitely don't want to damage. All right, switching gears a little bit to deep vein thrombosis and pulmonary emboli. So deep vein, so this is the deep veins, usually above the knee, and it's a thrombus. Thrombus is local, so this will have to become an embolus, which is going to exit the local area. Mercal's triad is something we talked about in hematology. So 3 things are going to predispose you to a clot: stasis of blood, hypercoagulable states, and endothelial damage. As an example, we can consider somebody after surgery. They're going to be bedridden, so that's stasis, check. They're going to have inflammation because of all the drugs and the damage to their body, check. And then there's lots of trauma, well, because they just had surgery, so check, lots of endothelial damage. Other risk factors will be things like birth control, pregnancy, and smoking, and obviously we're in the lung unit. These deep vein thrombi might, their first place that they might travel to cause damage is the lungs. So we can see the deep vein thrombosis here and see it a little bit there as well. So in the bottom part of the lung where the VQ ratio is lower, remember that the VQ ratio is lower. Yes, we have more ventilation because gravity pulls it down, but that has a much larger effect on gravity. So the overall ratio goes down. We're going to have more blood going there, which means we're going to have more clots going to the lower part of the lungs. Yes, the lungs have a dual blood supply, so they're somewhat resistant to ischemia, but nevertheless, there's 100,000 deaths per year due to pulmonary embolisms in the lung. So this can be defined as ventilation without perfusion. So if I have some perfusion, but my flow is 0 with a pulmonary embolism, so anything over 0 is effectively infinite. This is a VQ ratio of infinity. This is known as the dead space. This increases the AA gradient. This can be considered a type of obstructive shock. So we might see people with tachycardia and tachypnea. So this is going to be rapid onset pinpoint chest discomfort. So every deep breath or cough, pain is going to pierce the chest. This is known as pleurisy, where the pleura become inflamed and rub against each other, and this can be heard as a pleural friction rub. You can diagnose this with a D-dimer test, and you can treat it with heparin. So in about 20% of pulmonary emboli, you're going to see an S1Q3T3 ECG abnormality. That means that there's a prominent S wave in lead 1. So remember, it's a QRS. So it should go sort of like this, down a little bit, up a lot, and then maybe down a little bit like that. So this is my, let's take a look. That should be my Q. This whole thing should be sort of like the R, and this little thing here should be the S. Well, notice here we have a really pronounced S. Well, that's what we're talking about here with the S1. Q3 is going to be very prominent in lead 3. That's a lot more than this tiny little dip should be. And then the T wave is also going to be inverted. It should go the other way around for lead 3. So again, not everybody, but 20% of people. So that can be a useful diagnostic feature. There we go. All right, so the lungs can weather the storm, like we said. They have this dual blood supply. They're resistant to infarction, unless you have a really huge one, a saddle emboli, which sits right at the carina, which is where the 2 main stem bronchi are going to branch from one another. And you can see this on an axial MRI as well. Lines of Zahn, so these are formed in pre-mortem. So when someone's living and they get a clot, the high blood flow somehow causes kind of like rings on a tree stump. We're going to have platelet and fibrin red blood cells, platelet and fibrin red blood cells, platelet and fibrin red blood cells. So people get clots sometimes after they die, but they won't have these lines of zones. That's why they're a useful diagnostic feature. Again, red blood cells, platelets, and fibrin. So lots of different types. It's not just, oh my gosh, Bill Paxton, you monster. So it's not, he's injecting somebody with a syringe filled with air to kill them. It's inducing an air emboli. More likely you're going to see this in a scuba case where you go down really quickly, you compress a bunch of nitrogen in your blood, and then when you come up too quickly, it precipitates, it supersaturates, it comes out of solution and it forms air bubbles, which get into your brain. Fat emboli, if someone has liposuction or someone breaks one of their long bones, like the femur or something, fat can come out. This can get caught in the lungs, or even worse, it could go ahead and get past the lungs, get into the brain. Amniotic fluid emboli, during labor or a postpartum, amniotic fluid can break out and can form as a clot as well. Septic emboli, so heart valves and endocarditis, deep vein thrombosis can allow bacterial colonies to form, and these colonies can subsequently break off and become emboli themselves. Tumors as well can also become emboli. All right, let's kind of pivot and talk about the nasal cavity and sinusitis. So two types of nosebleeds, also known as epistaxis. Anterior nostril, which is where you break the Kieselbach's plexus. This is just a classic nosebleed, not a big deal. Posterior nostril, this is going to be the sphenopalatine artery, which comes off of the maxillary artery. This is very rare, but it's very life-threatening, and blood will go backwards down into the throat. So having a dry air can dry out the capillaries and make them susceptible to rupture. Picking your nose can honestly can induce endothelial damage, and obviously getting kicked in the face does not help. Nasal cavity is going to be lined with mucus. This mucus, is salts, and it sticks to bacteria and viruses, has lysosomes to degrade them, and then the mucociliary escalator can move them down your nasal cavity, down your pharynx, and down into your esophagus. Or, I guess you could spit it out, or pick your nose, or it can just go down into your stomach and be dissolved in the acid. Really, it's just a picture of what we just said. All right, sinusitis. So we have these really like empty paranasal cavities. The frontal sinus above the eyes, in the forehead region, ethmoid sinus behind the eyes and the medial side, not to be confused with the sphenoid sinus behind the eyes on the lateral side, and then the maxillary sinus right below your your cheeks, right below your eyes. This is going to be the main one, and then the largest one. The point of these is just that air comes in, it circulates around your sinuses, and it warms it, it keeps it moist, it captures bacteria and viruses and whatnot, and can put them into the mucus and the mucociliary escalator. The mucus is, again, eventually moved down. All right, so the drainage of this mucus. We have a general picture here, but specifically, they're going to drain out of the sinuses through these little cavities called ostium. So here we have another picture of an ostium, another picture of the ostium, the maxillary sinus, and they're going to move back down your throat through your esophagus. We have these three, I'm not sure if it's concha or concha, these three concha, the superior, the middle, and the inferior. And here we have our ostium where the drainage is occurring. So the pathway in here is called the meatus, and between the concha. So the superior meatus is where the sphenoid and the posterior ethmoid is going to drain. The maxillary, frontal, and anterior ethmoid are going to drain in the middle meatus, and the nasolacrimal is going to drain into the inferior meatus, shown here. So invading pathogens can cause an immune response. So it doesn't have to be pathogens. It could be infections. It could be environmental things or dust. It's going to cause your goblet cells to secrete more mucus as part of the inflammatory response. So this mucus buildup can cause facial pain, pressure, headaches, fevers. So infections can precipitate this, but then pathogens can also thrive in the mucus that's generated. Changes in your voice and your sense of smell. So if air can't circulate, part of the reason that you sound the way you do is because not only does air coming in circulate in your sinuses, but air coming out can circulate in your sinus as well, and it can get clogged up if there's too much mucus everywhere. And it might be worse when you're lying down because it allows more mucus to come back into your sinuses. So a similar thing is aspirin-induced asthma. So remember that aspirin is going to inhibit COX, which means your more leukotrienes will be produced. And leukotrienes, for whatever reason, can cause hyperplasia of connective tissue in your nasal cavity. This can generate nasal polyps, which are completely benign, but nevertheless quite annoying outgrowths of inflamed tissue. Shown here, shown here, and they can block normal mucus flow. So this can cause a mucus buildup. A deviated septum as well can be just as pesky, causing being a hindrance to mucus drainage. Note that the sphenoid sinus, if it gets a pathogen and mucus buildup, this infection could spread backwards into the cavernous sinus, which allows it access to the brain and into the meninges as well. All right, you can probably get about 20%, 25% of the questions just if you know how to read an MRI or a chest x-ray or know which lung sounds you're expected to hear. So it's pretty useful to go through all of these. So I guess here we have 15 different ones, and by the end, hopefully all of these fall into relatively clear categories. So on the left, we're always going to have a normal one, and on the right, we're going to have our pathological x-ray. So again, we're looking at the costophrenic angle. We're looking at a diaphragm that is relatively, that's not particularly flat. We want it to be, relatively translucent, but not overly black. These are all things that we're keeping in mind and making sure that the esophagus and the trachea are straight and not deviated towards one side or the other. So with that in mind, let's go ahead and take a look at this. I see a flat diaphragm. I see very radiotranslucent. This is emphysema. Here I see that the trachea is kind of at an angle. It's pushed over to the right. This is a little radiotranslucent. This is likely a tension, specifically tension pneumothorax, so much pressure that it is pushing the entire mediastinum over to the contralateral side. Keep in mind that atelectasis might pull potentially the trachea over to one side or the other. Here, potentially this could be a pleural effusion, but this is likely lobar pneumonia. Here, this one's kind of a giveaway. We've got a P for pancostal tumor, but we just see this coin lesion up towards the apex of the lung, and that's a clear giveaway there. Looking at this, we see a little coin lesion, so we're almost certainly looking at a lung cancer. In addition, I see unilateral, not bilateral, hilar lymphadenopathy. If it was bilateral, it could potentially be a sarcoidosis or tuberculosis. It could be a cancer if the cancer spread to both sides, but this is likely going to be just a unilateral side. And noticing that we have a central cancer, it's likely to be a small cell lung cancer rather than a non-small cell lung cancer. So we'll go ahead and say oat cell or small cell lung cancer here. Same general idea here, but now I see that this is not central. So remember the S was for small cell and S was for squamous cell. And so this is neither of those. It's a non-small cell. I'm assuming that this is adenocarcinoma just because it's the main one. We don't really know at the end of the day. You're not going to just go off of the chest x-ray. This is just definitely going to help you out, but you should have other, they're going to mention that it's a woman. They're going to mention that it's non-smoker, something like that. Maybe that it's CRAS or EGFR positive. Here we see this nice honeycombing pattern, this reticular opacities. This could be atypical pneumonia, also known as interstitial pneumonia. Could be pulmonary fibrosis. I don't really know. I find it very difficult to tell. I think if you can get it narrowed down to those two, you're probably in good footing. So this is probably a pleural effusion. Pleural because it's on the periphery and it's just so damn opaque that it couldn't possibly be a couldn't be anything other than just massive amounts of fluid. They're probably lying on their right side, which is why, that'd be my guess for why it's pushed over to there. I don't know, maybe it's pinned up for some reason as well. This, I'm guessing, is just a pleural effusion, but someone's laying down, or gravity is now bringing this down to the inferior portion of the lung. Here again, not really a trick question, but I'm not above putting the same thing twice. Emphysema is really common. You guys should really know what it looks like. This is a very flat diaphragm. We have a very expanded rib cage, so this barrel chest, and again, this is a little bit radiolucent, so this is also going to be emphysema. Again, I think we've got another emphysema. Wow, I really loaded you guys up on emphysemas. Again, very radiolucent, relatively flat emphysema. Here, this always kind of looks a little bit like pulmonary fibrosis, but here you have this diffuse, not slightly homogeneous, but it's just a little bit like fuzzy, a little bit blurry. This is ARDS, acute respiratory distress syndrome. Looks a lot like pulmonary fibrosis, but I think it's really good to differentiate the two. Here we go again. So notice this is ARDS. This is a pulmonary fibrosis, potentially an atypical pneumonia. Here we see highlighting of the hilar. So this could be a lung cancer, but it's on both sides. There's a little bit of reticular formation opacities, this honeycombing kind of. I bet if I saw an axial MRI, we could see it better. My guess would be tuberculosis or sarcoidosis. Let's go with sarcoidosis. All right, here we're seeing this giant thing over there. Notice that this is radiotranslucent, so this is this must be a pneumothorax. Yeah, this would be a pleural effusion if it was a little bit more opaque. Here we go. This is a great example of something that is opaque. This is going to be a pleural effusion. All right, let's go and see if we can get all of these. First one's normal. I'll give you that one. Here we have lobar pneumonia. Here we have a adenocarcinoma, or some sort of, if you get points, if you can just tell that it's a non-central lung cancer. Here we're going to see these hazy, blurry infiltrates. This is ARDS. Here we have the hilar lymphadenopathy. I see kind of reticular formation, maybe sarcoidosis. Over here, let's say atypical pneumonia or pulmonary fibrosis. It's really hard to tell which one, so we'll go with either. Here we have a pleural effusion, which gravity has brought down. Here we have this large expanded rib cage. We have this flat diaphragm, and it's relatively radiotranslucent. This is emphysema. Here I have, again, this is going to be another one of those atypical pneumonia or interstitial fibrosis, honeycombing, you can tell, as well with the axial MRI. Here I have a pleural effusion, but I think someone's just lying down on their side. Looking at this one, we have a flat diaphragm. Notice this as well. You see this in a lot of them. This is just your bowels. This is just your stomach filled with gas. You're going to see this in a lot of different things, and it's it's nothing to worry about too much. I mean, not to worry about at all, right? It's below the diaphragm, so it's just, do not confuse this with a pathology. Anyways, looking at this again, we tension pneumothorax because we see that the trachea is shifted over to the right, and this is a little bit radiotranslucent compared to the other side, which means more air is in here, pushing everything over that way. Here, flat diaphragm, very dark, emphysema. Here I have a coin lesion. I have an hilar lymphadenopathy. It looks unilateral. I'm going to go with a lung cancer, non-central one. So it could be squamous, could be small cell. Let's go with small cell. And over here, again, gosh, am I really putting that many emphysemas? I think I see a flat diaphragm. I see another radiotranslucent. Yeah, that's emphysema. And then the last one, again, the P is kind of dead giveaway, but this apical tumor is going to be a Pancoast tumor. All right, so percussion, if there's more air in your drum, it's going to be louder. So emphysema, pneumothorax, it's going to be hyperresonant. If it's a little bit more solid, or if the air is not there, atelectasis, consolidation, effusions, fibrosis, less air or more fluid means it's going to make less sound upon percussion. Fremitus, though, fremitus, it's not, maybe it's hyperbolic to say it's the opposite trend, but we're looking at the vibration of the chest wall. And sound travels better through a solid, through a liquid, than it does through air. So most things will get quieter with fremitus, but consolidation, where I have tons of exudate in my lungs, like a lobar pneumonia, will make it denser, and that will make it louder. Normal breath sounds. So I think we went over this recently, but let's just take a listen. Notice up, down. That is our bronchial breath. So you're normally going to hear bronchial breaths if you go ahead and listen to specifically the trachea. You could potentially hear this. But if someone has lobar pneumonia or something like that, or a pleural effusion, then you might just hear it in other parts of the lungs, where typically you should only be hearing vesicular sound. So let's contrast this with a vesicular sound. Up, quick down. Up, quick down. So that's vesicular, that's normal. Again, bronchial is technically normal as well, but it's only normal in these two regions, not really anywhere else. Vesicular should be here, but not if you have pneumonia or pleural effusion. So an adventitious sound is one that doesn't really belong there. That's a response to some sort of stress. So wheezing and rhonchi kind of go together. This is for obstructive, it's going to be on exhalation. Crackle and rails is going to be when there's fluid in the lungs. This is mostly an inspiration. And a pleural friction rub is going to be painful, and it's going to be particularly loud. So wheezing is the main one. Rhonchi is a little bit outdated, but obstructive, inflammatory, air has, there's turbulent flow, has a hard time getting through. You could hear it on expiration and inspiration, but it's going to be a little bit more on expiration usually. And rhonchi is technically like a deeper, lower snoring, and a wheezing is going to be a little bit higher pitch. So let's take a listen. All right, contrast that with wheezing. All right, rails and crackles. So it's going to be a little bit more short and explosive. Crackles really is a good name for it, bubbling, rattling, clicking. It's going to be worse with inspiration. This is when you have fluids in the lungs, pneumonia, also heart failure, of course, specifically left-sided heart failure. So we have two different types, high-pitched, kind of like the wheezing, and then coarse, the low-pitched, kind of like the rhonchi. So this is where this is going, the alveoli or the bronchioles are closed, but air moving through can pop them open, pushing them open. That pushing of the open, kind of like if a valve in the heart opens, can potentially make a sound that you could hear. So let's listen. Crackle, crackle. Crackle, crackle. There we go. All right, let's listen to this one. Okay. And then pleural friction rub. So this kind of sounds like, I don't know, I thought it was the sound that, it makes when you walk on fresh snow. A couple different things can cause this: pulmonary embolism, pleurisy, which is really inflammation of the pleura. A lot of different things can cause this, and pleural effusion. So it's going to be a really sudden, intense, sharp pain, specifically upon inspiration. And again, it's that when the lungs expand and contract, the pleura would want to rub against each other, which would create a lot of friction, would be painful, would make a lot of noise, but usually the pleural fluid stops that, but not if there's inflammation. It's similar to a pericardial rub when you have pericarditis. The difference is if you hold your breath and the pain persists, then and the sound persists, then you're dealing with a pericardial rub. It's a heart issue. But if it stops when you stop breathing, then it must be a pericardial rub of the lungs. And it's going to be particularly loud considering that the pleura are on the periphery, and that's where auscultation is occurring. So let's listen. All right, and then stridor, specifically if you get something stuck in your trachea, your upper respiratory tract, or if it's a child that has croup, you're going to hear this. And all of these together. I think we have our rhonchi. Let's take a listen here. And we have our fine crackles. Let's listen here. That's our wheezing. Let's listen here. I think that's our rhonchi. That's our coarse crackles. We know this one's crew. Yep, and a pleural friction rub. Oh gosh, what a symphony. Last section, let's talk some pharma. So 3 major things we're going to be talking about are histamine blockers, pulmonary hypertension or antihypertensive drugs, and then asthma drugs. So histamine blockers. First generation, look for N-ene or N8. So diphenhydramine, also known as Benadryl. Major side effect, it makes you drowsy. That's what separates the first generation from the second generation. The second generation ends in adine, example, loratadine, also known as Claritin. And this is non-drowsy, which is its main feature. So these are just going to prevent, basically going to block the effects of histamine. Alpha-1 agonist. So if you have a runny nose, that's because there's inflammation in your nose, there's too much fluid going there, you know, this hyperemia, too much blood flow going there, too much, it's going to cause edema, just fluids are leaking out, and you know, that can go forwards and that can go back. Well, one way to, you know, prevent that would be to just limit the amount of blood flow that gets there. So alpha agonists are vasoconstrictors. So if you take these, they will constrict the blood vessels, causing less fluid to get into your nose. These are, I mean, just think of the fact that epinephrine is an alpha-1 agonist, and so these, you know, epinephrine is epiphrine, and these have ephrin and ephrin in the names. That'll be helpful. So phenylephrine is Sudafed, and it is a alpha-1 agonist, and it is going to help you with congestion specifically. N-acetylcysteine. So if you have too much mucus, this is mucolytic, so it'll break up mucus. How does it do this? Well, there's a lot of different components of mucus, but proteins are really important, specifically disulfide bonds. So this is going to disrupt disulfide bonds by reducing everything. So here I have a disulfide bond, here I have a disulfide bond, now I have it reduced. Also, side note, this is useful for acetaminophen overdose. So acetaminophen has a lot of different ways of being processed. One of them involves glutathione. This is going to be a particularly non-toxic way of metabolizing acetaminophen, but you might run out of glutathione. But if you have N-acetylcysteine, this can pair with cysteine and ultimately be converted to glutathione. So basically you have more glutathione stores, so you can continually run this pathway and safely metabolize acetaminophen. All right, pulmonary hypertension treatments. Endothelin is going to be the main protein that causes, or the main signaling molecule that induces hypertension in the pulmonary system. So a receptor antagonist would be really helpful here. Bosentan is the main one. This is hepatotoxic as a side effect. Sildenafil, also known as Viagra, don't pair with nitrates, is a PDE5 inhibitor. Remember that everything on this side causes relaxation, everything over here causes contraction, and prostacyclin analogs. So we see prostacyclin here, which would be on the relaxation side, you know, antihypertensive. Prost, look for the drug with prost in the name. Side effects are flushing and jaw pain. All right, asthma drugs, feel free to read this, pause it. All right, let's go through asthma again. So a dendritic cell interacts with an antigen, could be cockroach, could be dust, could be pollen. and it's going to present that. It's going to generate Th2 cells. Th2 makes IL-5. IL-5 is going to cause eosinophil poiesis and activated eosinophils. Also, the Th2 are going to stimulate B cells to class switch with IL-4. So these now produce IgE, which coat mast cells, which allows it to interact with whatever our antigen is here. And there's just a hyper responsiveness. This is going to release histamine and leukotrienes, and it's cause bronchoconstriction in addition to the damage that the eosinophils do, and that's asthma in a nutshell. So how do we stop this? One, just avoid exposure. If you're allergic to dust or pollen, flowers, then don't smell them. Try to avoid triggers. So another one is we can imagine preventing the scandal before it occurs. So before the immune response occurs, let's stop it from occurring. So one way would just be to inhibit IgE. If you inhibit IgE, then it's difficult to have your mast cells armed and ready to interact with this antigen. So that is one way. Another way is to provide Zolutin. So Zolutin is a 5-lipoxygenase inhibitor. Leukotrienes are going to be particularly necessary for the asthmatic response, and you need 5-lipoxygenase to do it. So if you have Zolutin, you won't have this, and you might not have as many leukotrienes. Alternatively, we could have cromolyn. Cromolyn prevents degranulation. So different than antihistamines go after the histamine, this prevents degranulation. So it prevents the histamine from getting at the granules of the mast cells. Alternatively, like the ultimate anti-inflammatory drug should be a corticosteroid, right? Because this is going to inhibit the arachidonic acid production in the first place, so I don't get any of this. So this is going to stop all of this and all of this, and so this could certainly help. We have inhaled versions, which is something like fluticasone or budesonide. These are going to be less severe than like an oral prednisone corticosteroid medication, but there's less side effects. One thing though is if it's a spray and you spray it on your tongue, what that means is technically your tongue and your pharynx where you just spray this now have reduced immune system, anti-inflammatory properties, which means a pathogen that's opportunistic could actually have a better chance to colonize that piece of tissue. So if you do an oral spray, make sure that you go ahead and rinse your mouth to try to get rid of any pathogens, to wash them out so that they can't take advantage of the weak spot where you just sprayed in your mouth. Prednisone is oral. This is a little bit more intense, more severe, but there's going to be more side effects as well. Cool. Just a reminder that corticosteroids also, in addition to inhibiting, leukotrienes and prostacyclines and whatnot, also are going to inhibit many just cytokines and chemokines by inhibiting NF-kappa B. So this whole page is now thinking like, okay, the immune response has already occurred a little bit, but let's do damage control. So why do I have corticosteroids here? Because this exact reason right there. Corticosteroids, even after we've had we've been sensitized, we have an asthmatic response that's being initiated, corticosteroids are still good at helping cut down on it, sort of doing damage control. Additionally, we can think of, and by the way, everything that we talk about from here on out is going to be damage control, not just this slide. So another thing would be leukotrienes, remember, are going to be particularly important in this process. We tried to have Zolutin maybe to stop the leukotrienes from being produced, but if they do get produced or you have the response anyways, you could alternatively block the receptors. So usually things are named after the precursor, so Luc is in the name, so montelukast and zevirlukast are inhibiting the leukotrienes from doing their job. This would be especially good for aspirin-induced asthma. Remember that if you don't have COX active, then you're going to have twice or 3 or 4 or 5 times as much LOX active, which means you get more leukotrienes. So more leukotrienes, these anti-leukotriene receptors are therefore, of course, super helpful. Anything ending in Zumab is really just an IL-5 anti-eosinophil therapy. All All right, so again, still in the damage response thing, um, uh, the if you're having a picnic, you of course don't need that much air. Air is always good, but you don't need to bring in extra air. You're just kind of chilling. But if you're fighting a bear or you have some sort of sympathetic nervous system response, you're going to need extra air because you don't know, evolutionarily your body didn't know how long you'd be running or fighting, so more air is going to be useful. So point being that muscarinic is a parasympathetic nervous system, is going to be for contracting, shrinking the bronchioles so that less air gets in, while beta adrenergic sympathetic nervous system response is going to be a relaxation, dilation of the bronchioles. So remember that things ending in all are going to be associated with beta. So all of these are going to be beta agonists. Albuterol is the short-acting one. Salmeterol and formoterol are going to be the long-acting. How do I remember that? Because albuterol is going to be the shorter name one. So this is 1, 2, 3, 4, 5, 6, 7, 8. I think this is 9, and these are 10. So 10 letters versus 9 letters. Albuterol is the shorter letter, and therefore it is the shorter acting. All right, now we have the muscarinic antagonist. Notice that if I agonize the beta or I antagonize the muscarinic, that's going to have the same dilating effect for the most part. So tiotropium is the long one and ipratropium is the short one. I just think of the fact that a T is always going to be bigger than an I. So if this is what my I looks like, then the T should be bigger, like all things, because it has this little top part as well. It's kind of stupid and silly, but it helps me remember. Beta dilates, as we've talked about, and adenosine dilates in the heart or in a lot of smooth muscles, but weirdly, it constricts in the lungs. I don't know why, but it constricts in the lungs. Adenosine and theophylline are sworn enemies. So theophylline is really just like milrinone, which is going to inhibit PDE3, which means we're going to have more CAMP. More CAMP is going to inhibit MLC kinase, which is trying to phosphorylate and cause a contraction, but inhibiting this then is going to promote relaxation. Long story short, this promotes relaxation, and I know adenosine here says that it should, but for whatever reason, it doesn't. Adenosine is going to increase the bronchial tone, causing a bronchial constriction, and theophylline and beta agonists are going to cause a bronchodilation. Theophylline is kind of like caffeine, which is, again, going to be an antagonist and opposite of adenosine. So just an overview, you have asthma. How do you want to deal with it? Avoid triggers, avoid antigens. Have omalizeb, which is an anti-IgE, which coats mast cells so that they can't release their histamine and leukotrienes. You could have steroids, which stop the entire icosanoid production assembly line. Budesonide, which is also inhaled. Remember that you have to spray to prevent oral flush afterwards, or prednisone if it's more severe and you don't mind the side effects. Cromolyn is going to inhibit the mast cell degranulation, and xyludin is going to inhibit 5-lipoxygenase, which is necessary for the production of leukotrienes, which is necessary for the bronchoconstriction that we see in asthma. So this is the preventing scandal side. Everything below is going to be damage control. So cat's out of the bag, but now we just want to mitigate any harm that's done. So you could continue providing steroids, ramping down the immune system, inhibiting cytokines. You could also, maybe there's leukotrienes that have been produced, but the monoclonal antibodies will block the receptors of the leukotrienes. You could also have the Zumab anti-IL-5, so we don't get as many eosinophils. And alternatively, on the other side, still under the damage control section, we can go ahead and realize that sympathetic is going to dilate more air in, parasympathetic is going to constrict less air in. The beta agonists, ending in all, this is short, this is long, and this is long. Why? Because these are longer words. This is short and this is long. Why? Because a T is longer than an I. And all of these are going to dilate. Remember that adenosine normally dilates, but it actually constricts in the lungs. Theophylline is going to be the sworn enemy of adenosine and is going to also facilitate dilation. Don't forget methacholine as well. That's not really helpful. In fact, that's hurting, but it's useful to diagnose asthma. If you think about the term methacholine, choline, acetylcholine, this is parasympathetic. This is going to be a muscarinic agonist, not antagonist, but agonist, which means it's harder to breathe. Now, that's going to make somebody who's not asthmatic harder to breathe, but if you're asthmatic, you're hyperresponsive, it's going to have a more pronounced effect on you, and that's how we diagnose you. And we did it. All right, hope that was helpful. Good luck to everybody.